We are live, ma'am.
Very good evening to one and all of you. We are back with all of you again with our PG update webinar on oculoplasty this time. We have tried our best to be as relevant as we could, and we have an expert team to teach you and answer all your essential queries. So please do remain connected with us for our further PG updates, and also visit our website to have a relook on the previous webinars which you might have missed. Our expert panel is the best of the best and has Dr. Grover, who is here to join us, Dr. Usha Kim, Dr. Kasturi, and Dr. Santosh at the helm of it. Our moderators are Dr. Akshay Nair from Mumbai. He's from Aditya Jyoti Eye Hospital with an extensive training in oculoplasty in the premier institutes in India and abroad, has publications in 18 text journals and contributions in many book chapters on oculoplasty, and a reviewer of many journals. Besides, of course, his innumerable achievement awards and accolades. Dr. Harshul and I from ARC would be moderating besides him. So we shall, without delay, go on to our first speaker. It's Dr. Mukesh, a versatile surgeon who needs just no introduction. He's the medical director of CFS Jaipur. He has been the general secretary of Oculoplasty Association of India, has held all the major posts at Jaipur Ophthalmic Society. You name it, he has done it. He has also been the joint secretary of OPAI and been in the management committee of AIOS, besides his innumerable awards and gold medals, both at state and national levels. Dr. Mukesh is going to be talking on lacrimal surgeries and overview. I'm sure it's a very essential topic. So let's all tighten our seat belts and get into the webinar. On to you, Dr. Mukesh.
Thank you, ma'am. At the outset, I am thankful to Dr. Chitra and the whole team of ARC, Dr. Harshul and all others for giving me this opportunity and also for giving such nice introduction. I'll be speaking on lacrimal surgery overview. I believe it's a PG seminar. So to present an overview of lacrimal surgery may require 1 or 2 minutes extra. I am being given 10 minutes. So I'll take liberty of using 1 or 2 minutes extra if permitted for that. Like in the beginning, I should stress that anatomy of lacrimal system, we all should keep in our mind. The dimensions of lacrimal system, if you talk about canaliculus, it's around 10 millimeter, lacrimal sac 10 millimeter, NLD 10 to 12 millimeter. If you combine all of them, it becomes around 32 to 35 millimeter. Whenever we are attempting a probing in a child, then we should keep this dimension in our mind, and we should never insert our probe more than 4 centimeter in any case. I have seen people piercing probe, piercing floor of nose and entering into the pharynx. So in the beginning, always mark your probe at 4 centimeter. This is your guideline, and you should not be inserting more than this whenever you are doing probing. So anatomy gives you help in many things. We all know about epiphora and lacrimation or pseudoepiphora. Epiphora is watering due to abnormal tear drainage system, and very important finding is in epiphora or in true epiphora, you will have a wet lacus lacrimalis, while in lacrimation or pseudoepiphora, you will have a dry lacus lacrimalis. So in this particular patient, you are seeing a full lake of tear, while here it is dry, though the patient will complain of watering in both the cases. So one can differentiate between true epiphora and lacrimation from a distance itself. There are certain tests which one can do in epiphora evaluation. I will not go into these details, but one important and very simple test is bitter test. This is of great importance in COVID era. Just instill a bitter drop solution, chloramphenicol, typically in conjunctival sac. If patient is able to taste this in 5 minutes, it confirms lacrimal passage patency, anatomical as well as functional both. So you need not to do syringing or any other test. Just put one eye drop and your job will be done. Anatomical tests, syringing, probing, DCG, CT, MRI, we will not go into these details. Functional test, a very simple test which have been devised by us only. Bitter test, this is of great importance. Then fluorescent dye disappearance test, Jones dye test, lacrimal scintigraphy, we all know about it. Dye disappearance test is of great importance in a child, infant especially. You instill one drop of fluorescent dye. If dye does not remain there in the eye, say after 5 minutes or so, passage is patent. If it is there, it means there is some blockage. So this is about evaluation of epiphora. Now I'll come to the treatment or management part of epiphora. In congenital epiphora, you give Krigler's massage typically at least till 6 months of age. Generally, we do it till 9 to 10 months of age, and ideal age of probing for me, it is never less than 10 months, and I do it between 10 to 12 months of age. If it resolves on probing, fine. Otherwise, after 3 weeks or so, you can repeat. But before repeating probing, a thorough nasal examination should be there to rule out these nasal problems. And if a common thing is turbinate hypertrophy, for that turbinate in fracture is also simultaneously done. One can do silicone intubation also. If DCR needs to be done, it is never done before 3 years of age, typically after 4 years of age. This is how Krigler's massage should be done. Ideally, you ask a clinician, an ophthalmologist, how to do massage in a case of congenital epiphora. Everyone will tell you in a different manner. So ideally, what should be done is you just stabilize the head of a child and put your index finger, your nail should be facing the cornea, and your finger should be closing the eyelid. You just pull down on the lid so that your finger itself will be closing the lid little bit, and then press it over the sac area and bring it down. So you are stabilizing the head, your finger nail is facing the cornea, and your finger itself is pulling the lid down. Probing, ideal age of probing is 10 to 12 months, though early probing is indicated in congenital mucocele and acute dacryocystitis. One trial of probing, though it is almost mandatory prior to doing a DCR in a child, we do it even up to 7 to 8 years of age, and sometimes we are successful. While probing, always use proper size probe, 0 or 1. Never use thinner probe because there are chances of creating false passage, and direction is downward, backward, and laterally. We all should keep this in mind. And as I stressed out in the initial part of presentation, do not insert more than 4 centimeters of probe in any case. So a brief video on probing. This has to be done under general anesthesia. Intubation is not must, but preparation of intubation should be there in all cases because at time you may require urgent intubation. So then you keep paraffin or some ointment to lubricate your punctum dilator and probe. Lubricate your punctum dilator. Ideally, probing should be done from upper puncta. If it is quite narrow, one can do it from lower also, but ideally it should be done from upper puncta. So just dilate the punctum by your punctum dilator, Nittleschip's punctum dilator. Then use proper size probe, 10 or 1 number. Just hit the bone, pull it slightly towards you, and then change the direction. And this direction is downward, backward, and laterally. Now you are not supposed to insert it more than 4 centimeters. You have negotiated the block. After negotiation, you may do some reaming motion just to enlarge the opening which you have created. And then just for demonstration, we can measure how much probe we have inserted. And in this particular patient, it was I think 35 centimeter or so. Then the syringing is done. There is one peculiar entity which is congenital lacrimal fistula. Previously, a DCR used to be advocated for this. Now, by doing a simple fistulectomy, Dr. Ghosh from RP Center has advocated this. One can get rid of this fistula. So just delineate the fistula. One can do syringing. One can see the fluid is coming out through the fistula. Make an elliptical incision around the fistula. Just dissect out the tract, fistula's tract. And after dissecting out this, one should pass a purse string 6-0 Weichwell suture all around the fistula's tract. It becomes pear shape where this tract is communicated to the sac. You have to dissect out till it becomes pear-like. So that will be the communication of fistula's tract with the sac. And at the bottom of pear, just pass this purse string suture or fistula's tract. So you are basically passing a string kind of suture around the fistula's tract at its neck. Then just pull it, tighten your suture, and finally excise the fistula's tract. So very simple surgery, and if done correctly, then in 100% of the cases, you will be treating out the fistula properly. Then do remaining suturing in 2 layers. Now coming to the watering in adult, again we have to do proper evaluation of epiphora. If there is punctal stenosis, then repeated dilatation and snipping of puncta may be successful. In some of the cases, we pass mini monoca stent also after doing snipping. In proximal canalicular obstruction of less than 8 millimeter, canalicular trephination with stenting by mini monoca, it is quite successful procedure. In our hand, it is successful up to 70 to 80% of cases. Rarely, you may need to do conjunctiva DCR in those cases where it is almost plastered. The canalicular system is almost plastered. If canalicular obstruction is 8 millimeter away from puncta, then canalicular DCR with intubation has to be done, and one can excise the blocked part under direct visualization. If there is nasolacrimal duct obstruction, then DCR is the procedure of choice unless it is contraindicated. There are certain contraindications of DCR. We'll discuss those in detail little later on. External DCR, it is still considered as gold standard in spite of endonasal boom. It is, I will say, almost, it is only procedure for a failed DCR, laser DCR, or failed endoscopic DCR, or failed external DCR. Though one may do endoscopic DCR in failed sac surgery, but still external DCR will always have an edge in failed surgeries because you can directly see. One can handle fibrous or fistulous cases. Also associated common canalicular blockage may be managed, and it is the most successful single procedure. In DCR, nasal packing, it is a simple thing, but it is of great importance. So I have just highlighted the direction of nasal packing should be superior. It should point out towards the center of orbital roof or middle canthus. Generally, what we do is that we pass our, we insert our nasal pack little medially, and ultimately we land up in pharynx. DCR incisions, there are 2 incisions. One can give either a curved incision which is 3 millimeter away from medial canthus, or a straight incision which is around 10 millimeter away from medial canthus. Angular vein need to be avoided in both the incisions. Generally, it passes between 5 to 7 millimeter from medial canthus, so your incision should not land over the angular vein, otherwise there will be bleeding. The other incision is transcaruncular. A typical case of PCR surgery. Here I am giving 10 millimeter incision. Though there are select group of people who says that this scarring is quite significant in this distal incision, but I don't find scarring is significant. I never give skin incision by RF cautery. I feel if we give it by RF cautery, definitely there is a little more scarring than when we give it by scalpel. Traditionally, we pass stay sutures, then you just dissect and isolate your MPL, medial palpebral ligament. This is your medial palpebral ligament. Now you can use your RF cautery. It is not mandatory to cut the anterior part of medial palpebral ligament, but if you cut it, you will get more exposure. So this is the lacrimal fossa, and sac has been everted laterally. So once you have done this, then a probe is passed from puncta. This probe will tent up the sac, and then you can incise the sac. You can make sac flap. If you are making one flap, then make a large anterior flap. If you are intend to do two flap suturing, then you will have to make two flaps. So this is the flap, and this is the probe which has come out after making incision. After that, just break the thin lacrimal bone by your forceps itself. So this lacrimal bone, we could break it easily with our forceps itself. Sometimes it is thicker and you need to apply a little more of pressure. Then you inject some amount of xylocaine with adrenaline inside. That will serve two purposes. One, hemostasis. Second, it will separate the sac also, the mucosa also from coming into the punch, and then punch out the bone. Ideal size of bony opening is around 12 to 15 mm, and it should be directly in opposition with sac. If you make your bony opening little high up, then there will be sump syndrome. Then this is the large mucosal flap which has been created. You can see a large mucosal flap and large sac flap. These flaps are little larger, so I'll be removing some part of sac. There should not be any redundancy also in the flap, because redundant flap itself may fall and block the common canalicular opening. So just do the suturing and your surgery part is done. These are some of the points regarding preservation of nasal mucosa. I'll not go into the detail of these. And this is what I was highlighting. Your osteotomy should be directly in opposition with sac. You should not be creating osteotomy which is too high or too low. And ideally, your osteotomy anteriorly should include anterior lacrimal crest. Posteriorly, it should not include posterior lacrimal crest. It should remain little away from this. Superiorly, little above the MPL ligament insertion, and inferiorly at the lower limit of lacrimal fossa. So it is around 12 to 15 mm size. You have got liberty of moving little anterior and inferior. In case your mucosal flap is less, then you can go little more superiorly and little more inferiorly, but do not go posteriorly more or superiorly more. Sump syndrome, if your bony opening is too small and too high, then tears will be collected at the sac, at the anastomose soft tissue part, which will be lower than the bony opening. So by gravity, everything will be collected here, and your anastomosis will not drain out the tear. Suturing technique, one can do double flap suturing, which is the ideal, though single flap suturing also gives you good results. Partial flap, if your flaps are not proper, then it is okay. But if you are not suturing any flap, then your results will be unsure. Though in endonasal suture, DCR, generally this suturing is not done, but still nowadays people do little tucking of these flaps, so the results are good. If you do double flap suturing, then you will be having an epithelialized anastomotic tract, which logically also it should be more successful than the tract formed by a granulation tissue. There are certain contraindications of DCR, extreme old age, young patients, as I told you, it is never done less than 4 years of age, deranged BTCT. Then there are certain sac problems. Then there are certain nasal problems and bony problems. So there are 4 sets of problems which are contraindications for DCR. One, general set like extreme of age, deranged BTCT. Then sac problems like granulomatous infections of sac, TB, syphilis, rhinosporiosis, fungal infections, etc. Tumor of sac, very small fibrous sac. Nasal problems, if you are having polyp of nose, tumors, severe DNS and severe atrophic rhinitis. Bony problems, if there is extensive callus formation or fibrous dysplasia or craniosynostosis. So in all these conditions, DCY or DCT becomes an indication, dacrocystectomy, except of this. In infant less than 4 years of age, we do not do any sac surgery. Generally, we do probing. Then there is another surgical problem which is related with lacrimal system, canalicular repair. Very commonly encountered problem, so I included this also here. I'll take 1 or 2 more minutes. You just dilate the puncta. Finding this lateral cut end is quite easy, but finding medial cut end of canaliculus requires some dissection or some amount of visualization. It has to be always done under microscope. If finding this is difficult, then one very good thing is you can inject Rifen blue dye from opposite puncta, and this will nicely delineate your cut end of canalicular. Previously, we were using methylene blue, but that used to create messiness in whole of this area. Rifen blue will give you right amount of contrast. So this is the cut end of canaliculus, which can be easily delineated. Then you put in mini monoca stent after cutting it. It should not be too long. Generally, I do not place it more than 12 to 14 mm of mini monoca stent inside. I do not want dangling this tube dangling inside the sac. So you just thread your mini monoca stent with the distal cut end, then pass some pre-placed sutures in the pericanalicular area. Do not tighten them. If your stent come out here, do not worry. Just thread them again. Then tell your assistant to hold this lid, and finally just tighten your sutures. I have stopped passing vertical mattress suture in canalicular repair because I find that passing vertical mattress suture may damage the remaining part of healthy canaliculus. So I just pass some end-on sutures here directly, 2 to 3 end-on sutures, and that gives very good cosmesis. A delayed canalicular repair also can be done. In these cases, pigtail probe helps you tremendously. Just excise out whatever the fibrous tissue is there and use your pigtail catheter from healthy puncta. Pass out some non-absorbable suture, and you can later on thread hollow silicone tube also over these sutures. Thank you. Thank you for your patience here.
Thank you very much, Dr. Mukesh. That was a wonderful talk.
Yeah,
Dr. Akshay?
yeah, Dr. Mukesh, we have a couple of questions. There is a question that is for you. Uh, Essentially, it's asking about traumatic. Dr. Narendra Singh has a question. In traumatic NLDU, do you use intubation? Let me perhaps frame it this way. In which cases would you use an intubation for DCR?
Intubation, typically, I do not use it in a classical case of DCR, but wherever failure is anticipated, in a case of repeat surgery, I use this. In traumatic cases also, I use intubation set. And if there is some amount of fibrous tissue I find during surgery, the opening of common canalicular is not very smooth. I am not able to retrieve the probe very smoothly inside the common canaliculus opening. Then also I use the intubation set. But as a routine case, I do not use intubation set because I believe that putting in any additional thing may itself incite some amount of fibrosis. So unnecessarily, I do not use any intubation set.
Dr. Mukesh, I'd like to know that what precautions you take to minimize the chances of bleeding at the time of DCR. That becomes very bothersome sometimes, you know.
Yeah,
so what all
actually,
precaution you take before starting and during surgery?
yeah, actually, this is a very pertinent question, especially for our young surgeons. So precautions, they start before the surgery itself. We do some amount of nasal mucosal blanching by asking patient to use Nazivion or oxymetazoline nasal drop before the surgery. Blood pressure of patients should always remain under control because a BP of 150, which seems innocuous to us, but it may create great bleeding if you are doing a DCR surgery. Then the position of patient is of great importance. Always head end should be elevated by around 20 degree or so. Again, this will help you greatly, though we do not realize the importance of this, but this is also of great importance. And then after doing it, we inject xylocaine with adrenaline. Always give it some time. Do not start your surgery immediately after injection. Give at least 7 to 10 minutes for adrenaline to act. Then start your surgery. Keep your anatomical landmark in mind. Try to visualize the angular vein. In many of the patients, you can actually see it over the skin. So if you are able to see it directly, then avoid making incision over it, or else you have to make incision either medial to it or lateral to it, as it was highlighted. After that, once you are doing your surgery, then while making bony opening, your bony opening should not, it should be within the planned landmarks. It should not be quite posterior. If you are going quite posterior, then sometime you may have bleeding from ethmoid vessels, which is very troublesome. If you are going quite superiorly, then there is a plexus of blood vessel, fine plexus of blood vessel between nasal bone and the sphenoid process of maxilla, then also bleeding may occur. So you have to take in account about the anatomical landmark. Also, your packing is of great importance. Direction of pack should be towards medial canthus. It should not be going inside the pharynx. Then your opposition will not be there. So I think by keeping these things in account, one can get rid of bleeding. Always keep your suction with you. It will help you in case of bleeding, and some amount of bone wax and gel foam also should be there with you. In case of heavy bleeding, you can really take help of them.
One last question before we go on to our next speaker. During this COVID times, what modifications you have had to do for lacrimal surgeries?
Well, madam, during COVID time, ideally we should not be doing lacrimal surgeries. We should be avoiding it because we are working into the directly infected area, infected with COVID-19 if patient is infected. If at all you need to do it, you have to do it after doing 2 cases of COVID-19, two tests of COVID-19 around 48 to 72 hours apart. Then only take patient for SAC surgeries, and always use betadine copiously, 0.5 to 1.5% to 1% betadine inside the sac. Also wash it do a proper syringing with this diluted betadine so that your whole lacrimal system is washed off with any amount of bacteria. So these are the things which you can take into account, but repeatedly, the only problem is that you can do betadine irrigation initially during your surgery, but while doing surgery also there may be virus secretion through the tract. So ideally, you should be avoiding cases of DCR during this time. And if you are you have to do sac surgery, then do it after 1 or ideally after 2 negative COVID tests.
Thank you very much. Dr. Harshul, you could introduce.
Yes, yes ma'am. So it's a great pleasure to introduce our next speaker, who is Dr. Mohammad Javed Ali. Dr. Javed is a senior consultant oculoplastic surgeon at LV Prasad Eye Institute, and he's heading the Govindram Seksaria Institute of Dacryology. He's also a professor at various universities like University of Singapore. He's an adjunct professor at University of Rochester, professor at Alexander University at Nuremberg. So he's a senior scientist, and it speaks volume of his versatile presence in all the top institutes of repute world over. It's a great pleasure to have you, Dr. Javed, who will be speaking on management of a failed DCR surgery. Dr. Javed.
Thank you, Harshul. Am I audible?
Yeah, yes. Yeah, please.
Yeah, so in the next 10 minutes, I would be speaking on failed DCR surgery. And I thank Dr. Chitra and ARC for giving me this opportunity. This is a very wide topic, and obviously it cannot be covered in 10 minutes, but the idea behind is to give you an overview. And everything that I speak is already published by our group. So in case if you need details, you can have a look at those publications. And in case if you want to see the videos are also published by Springer. So you can have a look at them as well. These are my financial disclosures. So if you look at this paper that we presented, published in 2015 on the etiological analysis of 100 failed acrocystoidinostomy, these were the top 10 reasons why a DCR surgery can fail. And the topmost being cicatricial closure of the ostium, or either the size of the osteotomy has not been good, or the ostium is malpositioned. Now, if you look at these examples, these are examples of complete cicatricial closure of the ostium that you see over here. These are examples where the tube has been, with the cicatricial closure, the main cause has been the stent in this case, or could be a bad granulation tissue response around the ostium, or could be either a non-interfering synechia or interfering synechia, like you see here, turbinoceptal synechia. Or, the remaining, rarely it was possible that we may have misdiagnosed it preoperatively, or we missed a functional component, so those are rare causes. I won't go into those clinical evaluation because I can't overemphasize that any failed lacrimal surgery, the clinical evaluation should include every possible aspect of lacrimal system. The options for revising a DCR, well, there are more than 10 options that are available, but I'm just going to take you through revision external and revision endoscopy, which are the two common ones. And since the theme of this is also taking forward oculoplasty, I would be presenting the use of coronary angioplasty catheters for revising a DCR. Now, external revision DCR, you can see a scar already there, has already undergone external DCR. For me, any revisions, if it is required, now we have enough evidence in the literature that endoscopic approach to revise is far superior than an external approach to revise. Primary, maybe both may be equal, but for a revision, yes, an endoscopic approach is superior, and I'll exemplify why is it so. Now, if you see the incision, Dr. Mukesh has elaborated it very nicely. How to go about doing that. The idea behind when you do a revision DCR is to be able to expose the previous osteotomy. Like here you see this was the area of previous osteotomy. And the next principle is to make sure that the anastomosis that you see here is completely taken care of. And so you have a separate lacrimal sac area now, and this is the past osteotomy. And then the principle is to fashion and harvest the virgin nasal mucosa that is underneath this bony area. So that's exactly what is happening here. So I'm doing an osteotomy superiorly to harvest. What we can see that little bit of the virgin mucosa is available. And there you see that obviously it is not as big as a primary DCR, but it is sufficient enough for having a mucosa to mucosa approximation, like you see over here. And this is the pack that is there. You remove the pack, and then obviously you raise the lacrimal sac flaps again and go by the same principles. And obviously I use, for all my revision cases, I use mitomycin C as well as intubation. And in addition, I also use a technique of mitomycin C injection, which we publish, which is called as the COS-MMC technique. And then you obviously close as routine. So I won't go into those details. For an endoscopic revision DCR, I thought I'll just give you one example of what you cannot revise externally. Now, if you look at the possibilities of endoscopic approaches, the idea behind is why we go for an endoscopic approach other than skin, scars, and all those things is a large rhinostomy. A large rhinostomy is possible. You can identify the cause correctly, and that is very important. There may be many DCRs which will have multiple causes, and that is something that may be a little difficult when you are doing externally. And obviously the surgical trauma is much limited because you're quite focused on that. Let me just exemplify. I will not be presenting videos because the mandate of the time is 10 minutes, and I wish to honor that. If you look at this particular case, there is a complete cicatricial closure of the ostium, but look at that middle turbinate. The cause here for this failure is the middle turbinate, which has come and form a synechia, which is called as a turbino-ostial synechia, and that's the reason. So if you go and revise and without taking care of this middle turbinate, it's going to fail back again and again. So what I'm doing here is I'm taking a triangular incision to do something called as partial middle turbinoplasty. So you see there I've done. And once you get rid of the turbinate and you do partial middle turbinoplasty, you can see that the probe is coming beautifully into the thing. And now this is, you can see a partial middle turbinoplasty done here. And then you can see the common canalicular area. But there's still some kind of a scar tissue which is still above the area of common canaliculus, which you would go ahead, and this is a crescent knife, and you can go ahead and reflect the flaps, like you can see here, posterior flap here, and then the anterior flap here. And then you take a ball probe inside and go into the lacrimal sac to take care of any intra-sac synechia. Again, that is something that you would not be able to appreciate if you are doing an external DCR for a revision. And there you see the final picture of it. And then obviously, as I said, 0.2 mg% is what the mitomycin C concentration is there. And then I commonly use Crawford stents or Bika stents, but there are a host of options for lacrimal surgeons, and that is at the discretion of the lacrimal surgeon. Now, this is a minimally invasive way of revising DCR, and there are certain set specific indications where you can go, and there are certain specific protocols, like you inflate it for 8 atmosphere for 90 seconds, and then you again reinflate the balloons for 60 seconds. I won't go into those details, those are all published. But what is important here to remember is that each of these traditional dacryoplasty balloons approximately cost around 25,000 rupees. And that is something which is a little difficult knowing the economic situation in our country. So this is what we use. We use the traditional coronary angioplasty. Obviously, these are very, very long ones because they take through the femoral route. But we have published enough evidence on the utility of it. And the advantage is that you can do it for 4,000 to 6,000 rupees. So it's like 1/4 of the cost. I'll just give you an example of this case where not only there's a cicatricial closure, but there is an internal common opening threatening granuloma, which is there, which is also another cause. So what I'm doing is I'm going to get rid of the granuloma. I've aspirated the granuloma. So what do you see now? You see that the ostium is all cicatrized, and but there's the edges of it are all having granulation tissue. And even if you do a fantastic surgery, and if you don't recognize this little granulation tissue here, it's going to fail, meet the same fate. So what I'm going to do now, I'm going to do something called as silver nitrate cautery. So the silver nitrate cautery is done all around so that the granulation tissue will not recur. And there you see the probe coming up. And then this is the balloon that I'm using. This is a 3 mm balloon that I'm going to place in that area. And then you see how beautiful it looks at the end of it. At the end of it, this is the ostium. And you have hardly cut any tissue. You have not cut anything here. And you're able to achieve this thing. And then you see fluorescence is positive. And then you place intubation. And then this is what I'm doing is a circumostial mitomycin C injection to reduce the healing process. These are a few of the papers that we have published on this, so you can have a look at that. So in conclusion, I would say that we need to do a careful lacrimal evaluation, more so nasal endoscopy, to identify the exact causes of failure. And if you have your principles right, the management and outcomes are usually very successful. Thank you very much.
That was, yeah. Please, ma'am.
Thank you, Dr. Javed. We have a couple of questions for you. What would be your preferred duration for keeping the stent in place and removing it in a primary case versus a secondary case? Or?
Yeah, so either ways, primary and secondary does not depend on the duration. I usually keep it for 4 weeks. And no stent should ideally be kept beyond 4 weeks for 2 reasons. One, if you have done a good DCR, most of the healing happens in the first 2 weeks. At the most, epithelialization completes by 2 weeks. Even if you give a margin of 2 more weeks, beyond 4 weeks, there is no change in the ostium. So you have seen, if you've seen publications, we have shown up to 2 years, follow-up. Beyond 4 weeks, it doesn't happen. That's one thing. The second reason is that if you look at our ultrastructural studies on stents, where we have proved that beyond 4 weeks, there's a development of biofilm. And we know that when the biofilm starts developing, they tend to mount a reaction, inflammatory reaction towards the host, and we don't want any inflammation in that area. So taking these two considerations, 4 weeks is an ideal time.
Right.
Dr. Javed,
yes.
You said that endoscopic approach is superior to the external approach in cases of failed. So
Yes.
like, how do you decide that in which case you're going to go for external approach again, or this, depending on endoscopy, like nasal endoscopy?
Yeah, for me, external DCR is an exception. I usually do external DCR only if I'm teaching fellows for some, once or twice a year, but predominantly is endoscopy. One is it's quite easy. And then you finish the surgery within 10 to 15 minutes without hardly any 10-15 ml of blood loss. So, but for revision, yes, any day it is much superior. And if you look at the current evidence that is coming up from the Australian groups who have, my career is around 10 years. But if you look at those people whose career has been like 20, 30 years, they have now started publishing papers where even for a long course, if you look at somewhere outcomes beyond 5 years, even for primary surgery, now endoscopic surgery has a little edge over an external.
I think we have some very senior oculoplastic surgeon, also Dr. Grover, Dr. Kasturi. Let's take their opinion also on this point. Yeah.
May I ask Dr. Javed? Dr. Javed?
Yeah, Kasturi.
Very nice presentation. Congratulations. Javed, have you come across any case of nasal synecdoche? And if you have come across, how did you manage? Because those are real challenging situations. Yeah,
so the synecdoches, nasal synecdoches, then you classify them whether they are turbinoceptal synecdoches, whether they are osteoseptal synecdoches, or turbinoosteal synecdoches. And then you classify them whether they are interfering with the internal common opening or not interfering with the internal common opening. If they are not interfering with the internal common opening, then what you simply can do is once you do a good synecholysis, then either you cover it with amniotic membranes, both the sides, or if you don't want to cover with amniotic membranes, you get specific silicone sheets, very thin, fine silicone sheets that you can take it onto the septum and then suture it over there so that, it interferes with the reformation of the synecdoche.
And secondly, you have mentioned the silver nitrate, like it really works for the granulation tissue. So how do you apply the silver nitrate? Do you apply it in a roll gauze or you just flush it? So
I usually use silver nitrate sticks. Previously, people used to apply it on the gauze also. Nothing wrong with that. But silver nitrate sticks are very, very comfortable and very designed for an endoscopic approach. The only thing is that you should avoid keeping the endoscopy light when you are taking that inside, because light tends to activate the silver nitrate over there. So once you enter it, just have a look and then apply it exactly at that point. And it's quite beautiful in avoiding recurrence of granulomas.
Thank you.
So shall we go on to
sir? Yeah.
Thank you. I think Javed has covered the subject of failures very well. he's given the causes and he's told us about the management. I have experience only with external revision DCRs, and his technique was exactly the technique that we use. I think what I would take the opportunity to do is to point out 3 most important things that we ask for postgraduates, because this is a postgraduate teaching exercise. 3 most important things that I would ask in the Viva. One is, I think the answer that I get incomplete very often is, when a probe is given, what are the indications? You must start from diagnostic first. Talk about the diagnostic indications and then talk about the therapeutic indications. Second common instrument in Viva that you get is a punch. And the question that is often asked is, there are 2 questions. One is the size of the ostium, which has been adequately explained. It's best to explain it in terms of the landmarks rather than any particular size. And that should serve as a very good answer. The second thing that is often asked is the anesthesia. So you should know about the blocks, the intratrochlear, possibly intraorbital, and the local infiltration in addition to nasal and topical. So mention those things. I think that will be the most important thing. And lastly, about the failure, causes of failure, which have been beautifully covered by Javed, and the management. Very briefly, primarily the causes of failure. So those are the commonest questions that a postgraduate will face in his Viva. Thank you.
Thank you, Dr. Ashok. Nice to have you join us.
Thank
We
you.
shall now go on to our next speaker, Dr. Vidya, who's a consultant cataract and oculoplasty at the Eye Foundation. A very vibrant presence, very involved and driven with a penchant to deliver her best. So she is going to be delivering a talk on eyelid abnormalities, how to evaluate it. On to you, Vidya.
Thank you, ma'am, and very good evening. I shall be presenting to you on the evaluation of the eyelid malposition. Basically, I'll be taking you through ptosis, entropion, and ectropion evaluation. Ptosis can occur in all ages, and when a patient presents with droopy eyelids, we need to remember that it is mainly a sign and not a diagnosis. So we need to evaluate ptosis to find out the cause and arrive at the management plan. History is very important. The age of onset usually helps us to classify the ptosis into a congenital one and an acquired one. The history of diurnal variation and double vision usually points out towards the diagnosis of neuromuscular junctional disorders like myasthenia. We need to ask about the history of abnormal eye and facial movements. For example, this kid, when presented with a jaw winking phenomena, the diagnosis is quite obvious. It's a Marcus-Gunn jaw winking phenomenon. Sometimes patients may also present with complaints of droopy eyelids when they actually have some abnormal facial eye movements, facial dystonias like hemifacial spasm or apraxia of eyelid opening or benign essential blepharospasm. History of trauma is very important. It can cause ptosis in a variety of ways, like a levator disinsertion or a third nerve palsy. History is again important. When this child presented to us with droopy eyelids, he also gave history of double vision in our gaze. So we went ahead with scanning, which showed a fractured fragment which is impinging on the superior rectus, causing elevation deficit. So history is again all important in proper diagnosis. History of orbital surgeries and lid surgeries, again very important. When we have failed surgery like this, the patient is not happy with the outcome, we need to carefully evaluate the primary surgical plan. What we see here is a globe hypotropia, that is gross elevation deficit, and also he has Marcus-Gunn jaw winking phenomenon. A simple frontalis sling alone will not take care of this kind of complex situation. History of repeated lid swelling, as in this lady who has got repeated inflammatory lid swelling causing some skin changes, atrophy of fat, and levator dehiscence. Diagnosis classical blepharochalasis. Family history is very important. Again, we have familial syndromic ptosis conditions like blepharophimosis and myotonic dystrophies, which can run in families. We should not forget asking about the use of contact lens and the recent use of injection botulinum toxin when a patient presents with ptosis. Use of anesthetic agents and its adverse reaction in the family in the past we need to document that properly. History of bleeding tendencies is again important history. Systemic history is very important. Patient may not bother to tell us about recent onset of dysphagia or a climbing difficulty to us, to ophthalmologists, when they present for lateral ptosis evaluation, but that could be a clinching point in ocular myasthenia or myasthenia gravis. When we do our ophthalmic evaluation, we should start with checking vision and recording it. We need to discuss, many of these patients can also have astigmatism and amblyopia, and that has to be clearly discussed with the patient before we intervene surgically. Head posture is another thing that we need to check. Patients may present with head tilt or chin up position. In severe ptosis, we can find some compensatory mechanisms like brow elevation or chin up position to clear the visual axis. The presence or absence of lid crease is another important point. The absence of lid crease usually points out towards the congenital ptosis, and the high or receding lid crease points towards the aponeurotic type of ptosis. On down gaze, when we examine, if the patients with congenital ptosis, usually there is lid lag on down gaze. That is because of the dystrophy of the levator muscle. Whereas in case of aponeurotic ptosis, there is lid droop on down gaze. Ocular movements are very important so that we do not miss out on congenital complex ptosis and the neurogenic ptosis, the worrisome part of the ptosis. For example, in this patient, a classical congenital monoocular elevation deficit, wherein there is globe hypotropia and there is elevation deficit. So here the management plan would be to correct the hypotropia first, followed by ptosis correction. The neurogenic ptosis is one thing that we should not miss. Here is a patient with a classical third nerve palsy, presenting with ptosis and limitation of ocular movements, depression, elevation, and adduction. Any significant anisocoria, we need to evaluate these patients immediately with radiodiagnosis. MRI or MRA would be preferred to rule out the PCOM aneurysm, which is the most common thing. Patient with aberrant regeneration following third nerve palsy can usually present with lid retraction on down gaze, so otherwise called as a pseudo-vangraphy sign. Again, the treatment would be really tricky in these patients. As I mentioned, there is pupillary examination is another important point that we should not miss. It helps us diagnose the third nerve palsy and Horner syndrome. Phenylephrine test is useful in case of mild ptosis or patients presenting with Horner syndrome. Corneal sensation and dry eye evaluation should be to complete the ptosis evaluation. Bell's phenomena is very important. If there is poor Bell's phenomena, we might have to defer ptosis surgery at all. When the history is inconclusive, we might have to review the old photographs to get a clear idea about the onset of ptosis. Moving on to the quantification of ptosis with simple measurements like this, the palpebral fissure height, wherein we do with a simple ruler from upper eyelid to the lower eyelid across the pupillary reflex, that gives us the approximate height of the palpebral fissure height. And the difference between the two eyes usually gives the amount of ptosis. The second important measurement that we make is a marginal reflex distance 1, which is measured from the lid margin, upper eyelid margin to the light reflex. Normally it would be around 4 to 5 millimeter. Another important measurement would be the marginal reflex distance 2, which is done from the corneal reflex to the lower eyelid. So this is the marginal reflex distance 2. By making these measurements, we could find out the difference in MRD. The difference between the MRD of the two eyelids would give us the approximate amount of ptosis, and we can classify the ptosis into mild, moderate, and severe based on this. If it is less than 2 millimeter difference, then it falls into the mild variety. If it is more than 4, it falls into the severe variety. The all-important measurement in a case of ptosis would be a LPS action, the amount of LPS action based on which we perform our surgical correction. So this is done from the maximal down gaze position to the maximal upward up gaze position after negating the action of the frontalis. Less than 4 millimeter would indicate that there is a poor levator function, and more than 15 would be an excellent levator function. Levator function in a child is very difficult to measure. The indirect clue would be the presence of lid crease, which says that there is an adequate amount of levator function. Or the other words, presence of anomalous head posture again points out that it can be associated with poor levator function in a child. When we are suspecting neuromuscular junctional disorders like ocular myasthenia, simple tests like an ICEPACK test would be helpful, like wherein we make all ptosis measurements, then keep ICEPACK over the closed eyelid for about 2 minutes, redo the ptosis measurement. Any improvement in ptosis by about 2 millimeters usually points out that there is an associated ocular myasthenia. Another simple test would be to do a fatigue test, wherein we ask the patient to look up for about 30 seconds without blinking. The prolonged upgaze usually worsens the ptosis if it is ocular myasthenia, as in this patient. Once we're done with the measurements, we need to rule out these mimickers. One is the contralateral eyelid retraction, as we get to see in thyroid eye disease. The second thing is a ptosis, as in this patient. The third would be more common condition, the redundant upper eyelid skin, otherwise a dermatochalasis. There are simple upper lid mass like a capillary hemangioma, which can be easily treated with topical and oral beta blockers. Neurofibromatosis, which causes an S-shaped ptosis and associated with capillite spots. And our history should guide us towards the towards the diagnosis of post-traumatic enophthalmos, wherein there is enophthalmos and movement restriction as well. Moving on to the evaluation of ectropion and entropion. Normally, our lid margin is a square-shaped structure which is in close opposition to the globe, and the change from the lid margin to the conjunctiva is quite abrupt. As we age, there are different involutional changes that happens around the eye. One is the canthal laxity, this descent of the canthal position. There is also shortening of the intercommissural distance, and there is redundancy of the orbital septum and skin. All these changes might result in ectropion, which is an outward turned eyelid, or entropion, wherein the eyelid margin is turned inwards. A patient with ectropion can present with different manifestations like this, like chronically inflamed conjunctiva. In long-standing cases, it can as well go for keratinization also. There can be an exposure keratopathy. More commonly, they can present with punctal, lacrimal pump failure. And sometimes there can be post-traumatic conditions. We can expect this kind of cicatricial ectropion, wherein a scar is tend to pull the lid margin outwards. The entropion, which is more symptomatic than ectropion, can usually present with this kind of bunched out lower lid tissue, wherein there is overriding of this preseptal orbicularis over the dorsal orbicularis. There can be ocular inflammation because of the constant rubbing of the eyelashes against the globe. There can be also the canthal dehiscence from its normal position. And when we examine closely, we can have a deeper pharyngeal area, and there is an yellowish line which says there is detached inferior retractors. Many of these patients can also have fat atrophy and enophthalmos as well. Mind you, these kind of changes are expected in involutional entropion, which usually affects the lower eyelid. But if we get an upper eyelid entropion, we need to carefully examine the eyelids and conjunctival surface for symblyferon formation like this to rule out other cicatricial conditions involving the conjunctiva. Very simple test that can be done to evaluate the thing would be to assess the medial canthal laxity, wherein we pull the lid laterally, and lateral canthal laxity, and lid distraction test where we pull the lid outwards, and anything more than 6 millimeters usually says that there is horizontal laxity. The other simple test would be to do a snapback test, wherein we pull the lid outwards and allow it to snap back to its original position. If it doesn't snap back to its original position without a blink or it takes some time to go back to its original position, that again indicates that there is horizontal lid laxity. So to conclude, by doing a detailed evaluation, we can find out the type of malposition that we are dealing with. By performing the relevant clinical test, we can assess the severity of the condition, and also we can exclude the mimickers. We can formulate a proper management plan which would be successful cosmetically and functionally. Thank you.
Thank you, Dr. Vidya. will talk. Dr. Akshay?
Yeah, I think one of the questions that we have received is, what is the preferred management plan in Marcus gun ptosis, in basically ptosis with Marcus gun phenomenon?
I think Madam is going to cover that part of it. Dr. Usha Kim will be covering that anyway, but Marcus gun jaw winking phenomena, we need to check the flutters and we need to discuss with the patient that we may not be able to abolish the Marcus gun jaw winking phenomenon completely. The preferred management would be to do a levator disinsertion followed by frontalis link. That would be the procedure of choice.
Right.
Dr. Usha, do you have any question to ask? PG related?
No, I think I will subsequently cover the management. So if you can stop sharing, Vidya, I can.
Yes, ma'am.
Okay.
Dr. Harshul?
So, yes, ma'am. So it's a great honor and privilege to introduce Dr. Usha Kim. Dr. Usha Kim heads the Department of Orbit, Oculoplasty and Ocular Oncology at Arvind Eye Hospitals. She underwent specialized training in this field under guidance of Dr. William Stewart at University of California, USA. In 1998, Dr. Usha Kim started the department at Arvind Eye Hospital, Madurai, and under her leadership, in the last 20 years, this clinic has seen more than 5 lakh patients and performed more than 1.2 lakh surgeries. And so making it among one of the largest units for orbit and oculoplasty in the world. And she's also deeply moved by the plight of helpless patients who discontinue treatment because of ocular cancers for want of money. So Dr. Usha set up a Ring of Hope initiative in 2004. Till date, more than 7,000 patients have been treated free of cost under this program. She is also involved in key leadership position at Arvind Eye Care System. She is director of the Allied Ophthalmic Personal Training Program. And she is currently, we all know, the president of Oculoplastic Association of India. She is also involved in genetic research pertaining to retinoblastoma. She has more than 63 publications to her credit, and she has received many prestigious awards. Dr. Usha Kim. She'll be giving an overview on eyelid surgeries. You are muted, Dr. Usha. Can you unmute yourself?
Can you unmute? Dr. Usha, we can't hear you. Can you unmute yourself?
No. Mr. Sunil, can you?
Just
Yes.
a second. Yeah, yeah. Is it audible now?
Yes.
I'm sorry about it. So now I think I'd like to thank Dr. Chitra and the ARC team, and thank you for that kind introduction. It's a privilege to be part of this wonderful meeting. Though an extensive topic, I think I'll try to do justice in the time given. So let me start off with the slide. So the fundamental principles that I'd like to emphasize on would be a careful detailed history and give utmost respect for the functional requirement of the eye, pre-operative patient evaluation, which Dr. Vidya has done very well. The documentation becomes extremely important. Selection of the appropriate surgical procedure, type of anesthesia plays an important role, and of course the post-operative care cannot be undermined. So let's go straight to the different aspects of the congenital entropion. I'll be demonstrating the video because I'll make it fast now. So this is a particular case where there is a congenital entropion. Over here, I'm going to do a simple V's procedure to correct the entropion. You do a full thickness cut just below the tarsal plate and make sure that you don't go too medial because you'll cause a punctal eversion. Pass the suture through the skin orbicularis and then lower end through the conjunctiva and the orbicularis. Similarly, 3 such sutures are being passed, and then ensure that you don't evert too much of the punctum on the medial aspect. And make sure that there is a slight overcorrection so that it is becomes normal over a period of time. So that's the case preoperatively and postoperatively. Now coming to epiblephron, this is a fold of skin which is usually medial in aspect and accentuated on down gaze. And the treatment is pretty straightforward. Sorry. So here you just have to excise a portion of the skin and orbicularis on the medial aspect and apply sutures. So sometimes you can just leave it alone. Over a period of time, this epiblephron gets corrected. But when it causes a corneal problem, then you ought to do a surgical procedure. So that's basically what it is about. It's very simple and can be done by any practicing ophthalmologist. So the next procedure is the wheeze in an elderly person. I'll repeat this procedure because it's a very important and a very simple procedure. And often in the elderly patients, you come across this kind of an involutional entropion. And here again, you make a through and through incision just beneath the tarsal plate and then apply the sutures through the skin orbicularis, leaving the tarsal plate on the upper end, including the conjunctiva and the orbicularis on the lower cut end, and coming out through the conjunctiva and the orbicularis and the conjunctiva, and out through the orbicularis and into the skin. So you're making the sutures close to the lid margin, and there is an eversion immediately on the table that you can notice. Similarly, 3 such sutures, again care to be taken not to go too close to the medial aspect, because eventually it can cause a punctal eversion. So that's basically the sutures, and the extra skin can always be excised, and you can do the suturing just like in the previous case that I had shown earlier. Now coming to the quick cuts procedure. So the wheeze was without skin laxity and the quick cuts is with laxity. So here you can see you're combining a wheeze procedure along with an excision of a portion where you have the laxity. So you're excising a portion of the lid, lower lid, and then you are doing a wheeze procedure as shown previously. And in addition, you're trying to repair the excised portion. So that's what we're basically doing. So without a laxity, wheeze procedure is ideal. With lower lid laxity, you should do a quick cuts procedure. And it's pretty straightforward because you would do like any lid tear and approximate the cut end. That's how it looks basically. So again, in congenital entropion, as I showed you earlier, it was a wheeze procedure. Without laxity, again with wheeze procedure, and with laxity, we will be doing a quick cuts procedure. Now let's look at the Jones procedure, where I'm doing an external approach. You could do a transconjunctival approach as well. When you do the external approach, you would visualize the white line, which is the lower lid retractors, and all you need to do is reattach the lower lid retractors to the tarsal plate by using sutures to approximate the lower lid retractors and the skin, the tarsal plate through the skin. So 3 such sutures again. This procedure again can be done transconjunctivally also. Now in lower lid retractors retracting, you would see a white line as you in the fornix, where when you know that the retractors have retracted. So this is a procedure for plicating. Now let's do the tarsal wedge resection, which is a procedure for upper lid entropion. Here you need to excise a portion of the tarsal plate, and then you pass the sutures. Once the excision is done, you pass the sutures, careful resection of the tarsal plate. Upper lid entropions are quite difficult. It's often in cases of entropion, and there might be cases where you do repeat procedures. So here, what you need to do is pass through the upper edge of the tarsal plate, out into the lower portion. So which means you are reducing the tarsal plate height, which means you eventually evert the upper lid. That's basically what you need to do for a tarsal wedge resection. And you have to pass the sutures as shown. Now, lateral tarsal strip is a procedure done both for entropion or ectropion. So here you basically have to make an incision in the lateral canthus and excise a portion of the extra tarsal plate, and then you keep the tarsal plate devoid of conjunctiva and skin and pass permanent sutures through the cut end of the tarsal plate and approximate it to the superolateral aspect of the orbital rim. And that's how it basically is repositioned. Now, ectropion, you have involutional, mechanical, paralytic, cicatricial, and spastic. I'll quickly run through some of the procedures. So basically in ectropion, you need to revise the scar in cases of scarring causing ectropion. You could do a Z-plasty, which is 2 triangular flaps transposed to achieve the change in direction, basically change the direction of the pull. And then for extensive scars, you probably might have to resolve doing a skin graft. Over here, I just tried to show you, demonstrate how the different stages of the grafting. You actually have to excise the scar tissue and measure the amount of skin that is required. We often resort to taking skin from the post-auricular region. If it's very small, you can even take pre-auricular. If you need very large grafts, then you can even go to supraclavicular or upper forearm, and the skin is excised and then it's grafted. You can do it both for upper and lower lid. The size of it is important. You need to measure the amount required and you can slightly oversize it. Now you have a situation like this where you have an ectropion and there is a hypertrophy of the conjunctiva, which results in a scenario like this, for which you can just excise a portion of the extra skin in the form of a pentagon and reattach the tarsal plate to the orbital rim. And this is how you are able to achieve a result. Now let's look at the paralytic ectropion, where you might have to do a medial canthoplasty when there is a medial ectropion, a medial and lateral canthoplasty or a lateral tarsal strip in a generalized ectropion. You may also have to do a medial canthal resection. Now let's look at this procedure where there is an improper lid closure. So you can do a scleral spacer where you need to disinsert the levator and then from the tarsal plate and lengthen the levator aponeurosis by using a scleral graft. So the graft is sized in such a way that if there is a 1 millimeter lag off, then you need to add a 3 millimeter scleral graft. So here it's approximated just like you would approximate a levator aponeurosis on the tarsal plate, and the superior edge is attached to the cut end of the levator. So which means you are indirectly lengthening the aponeurosis, which gives a nice closure. So mild lid retraction, you can use a simple procedure like mullerectomy, where you just have to evert the upper lid and you can infiltrate the conjunctiva, and the Muller's muscle is attached to the lower end of the tarsal plate and goes into the levator aponeurosis. So all you need to do is make an incision on the conjunctiva and dissect the Muller's from the lower end of the tarsal plate and from behind the levator aponeurosis. So it's a very simple procedure and it's done for a very minimal lid retraction. So all you need to do is apply buried knots so that you don't cause any corneal abrasions. And this is basically a very simple procedure, and you use avical sutures. This can be used in very minimal retractions in thyroid orbitopathy as well. Now the surgical options in ptosis depends upon the amount of ptosis, the levator action and associated comorbidities, which was spoken very well by Dr. Vidya. So the gold standard for a congenital simple ptosis is a frontalis suspension, which I often use silicone material. There are many advocates of facial latter, but I prefer silicone because it's very simple and straightforward. I use the Fox pentagon, where you have 3 incision sites above the brow and 2 incision sites on the just above the lid margin. So you have to pass the needle through each of these incision sites, and caution not to damage the cornea underneath. So you can use a protective guard. So you pass through each of these incision sites and come out through the summit of the pentagon. Again, it's a straight needle which you can bend it to your convenience for the ease of passing through each of these incision sites. Once you bring it out, there is a sleeve through which you have to pass the needle and tighten the, so the point of correction should be at the upper limbus. And once this is done, you need to put a closure suture, because usually it's done in young children where they are under a general anesthesia. So closure might become a problem in these children. Now, blepharophimosis syndrome, Dr. Vidya did show a familial picture where it's acquired and it's autosomal dominant, where you have epicanthal folds, you have ptosis, and also telecanthus. So in this particular patient, I've done the EYELID and also done a little lateral canthoplasty and a frontalis sling. I've not done a telecanthal correction because it requires a transnasal wiring, and it is done usually when it is absolutely necessary. Now, as somebody asked, what do you do for a Marcus gun jaw winking? Here is a patient who has a jaw winking phenomenon and the flutter is significant and the patient needs a correction. So what do we do here? Here we do a skin crease approach where you have to disinsert the levator and you have to excise a large portion of the levator so that it doesn't go and reattach, and then you do the closure. On top of the levator resection or cutting off the levator, you also need to do a frontalis sling, because once you have the levator excised, you will end up having a ptosis. So you need to do an additional frontalis sling in this particular patient. Now, once the frontalis sling is done, like what we did earlier, you also have to remember that you have to measure the amount of flutter and also see which is predominant. Is it the ptosis that is predominant or the flutter that is predominant? So this, I did not show you the in the previous surgery, the sleeve that is being used, and that sleeve has to be buried deep into the subcutaneous tissue, underneath the subcutaneous tissue. And then the closure is done. Now we need to see how it has worked in this particular patient. There was a pre-op flutter. Now the flutter is gone and the ptosis is corrected. So basically in Marcus gun jaw winking phenomenon, which was a question asked, you have to do a levator excision. You have to be careful cutting the medial and the lateral horns, because even if a few fibers are attached to the tarsal plate, the flutter can remain. It's not very uncommon to have a remnant of these flutters, but it's okay when it's not a very large flutter. Now, Fasinella servate, I use that particular technique in this particular scenario. There is a neurofibroma here, which you can obviously see, but I tried doing a bit of a debulking and a Fasinella servate procedure where you do a tarsoconjunctival resection. And you can notice that in this particular scenario, it has worked very well for this particular patient. And it's very particular. You have to customize it. It's not possible in all the cases. Here we just debulked and did a bit of a tarsoconjunctival resection. And here again, you have to use buried sutures, and that's how it looks post-surgery. And this is the post-operative picture. Now here, again, a levator resection. I've combined it with the blepharoplasty in this particular case. So here you have an excess skin. I didn't want to repeat the surgery, so I excise the skin preoperatively. I mark the excess skin. I excise the portion of the skin that's excess. This is a case of blepharochalasis, so there is an excess skin there. And then identify the levator aponeurosis, which is attached to the tarsal plate. excise the pre-aponeurotic fat. You can either excise or cauterize and attach the aponeurosis to the tarsal plate. 3 such sutures are applied using the 60 Weichel sutures, which is absorbable. And once each suture is applied, you have to compare it with the other eye. Ensure that the contour of the upper lid is maintained. It has to be an almond shaped, ideally. Excise the excess levator, excess skin, and then apply sutures. You can apply with a non-absorbable or an absorbable suture. You always compare it with the other eye, both in the sitting posture and in the lying posture. So thank you very much. That's all from me at the moment. I'm open for questions.
Thank you very much, Dr. Kim. That was an amazing talk for all of us.
Right, ma'am. Ma'am, yeah. So, ma'am, there's a question for BPS, blepharophimosis syndrome.
Yeah.
When there are all 3 components, would you do it in a staged manner, or would you consider doing a single stage? Because I think Dr. Kasturi ma'am has also published her results, and there are a few other authors who plan doing it at a single stage as well.
Yeah, this is a most controversial topic, but my preference has been a single stage because it has worked in my hands. But I think we should leave it to the surgeon to decide. But my preferred surgery would be one piece. You do all 3 procedures in one single sitting, and it has worked very well.
Right. Ma'am, Dr. Kasturi, your opinion on this is?
Yeah, I do agree. Like whatever I have published, we have done a comparative study between the multi-stage and the single stage. We found that in India, one of the most, difficult situation comes because of the follow-up losses. The follow-up losses is so high, but I feel the multi-stage gives you a more better judgment and a more better evaluation, and you can titrate the amount of the revision or whatever you want to do. But because of the follow-up losses, we started doing single stage, and we found that there was no much difference between the two. But if you ask me, definitely multi-stage gives a better judgment and better result. But single stage is also an option.
I do agree with Kasturi on one point. See, what happens is when we try to correct the epicanthus, you have an obvious ptosis which is exaggerated. So if you give it some time, probably you will be able to make a better judgment. But the fact, as she's pointed out, is that we need to do the procedures in one stage. Otherwise, patients don't come to us, especially when it is to be done under general anesthesia. So I do agree. But our results have been quite acceptable.
I have a question, not a PG related question, but when you are counseling a patient for a functional lid malposition problem, against when you are advising a cosmetic blepharoplasty procedure, don't you think the way you talk to the patient is very different?
Absolutely. There is no doubt about it, because the expectation of the patient is like she would have a picture of some movie actress who's got all the very good features, but you will have to moderate the expectations and counsel them with the preoperative pictures and the some of the postoperative pictures as well. So counseling is the key to success. And always it's said that preoperative more talk and post-op less talk. Preoperative becomes an explanation and post-op becomes an excuse. So it's always better to counsel the patients upfront as to what to expect.
Dr. Kasturi, there is a question that what is the sequence of surgeries in a case of blepharophimosis syndrome? Like, what do you correct first? And
yeah, actually, blepharophimosis is basically a tetrad. It has a phimotic lid, it has a ptosis, it has got an epicanthus inversus, and also sometimes a lateral laxity. So what we basically do, like the first is you need to correct this hypertellurism or the telecanthus. So my first is always, I see the amount of hypertellurism, I measure it. If it is somewhere between more than 30, then I usually go for transnasal widening, and also I go for the Master Z plasty. But if I see that it is not so advanced, the blepharoplasty, it is somewhere between 24 to 30, then I go for YV plasty. When I plan for a YV plasty, then I go for single stage. But if I plan something like a Master Z plasty, which is actually a double YV plasty, along with the 2 transposition. And along with that, I do a transnasal widening. So that is number 1 I do. And then in the same time, because of the phimotic lid that we see, sometimes I also do a lateral conjunctivo plus a canthoplasty. That is very essential to increase the horizontal width of the eye. So that is the second stage I do. And lastly, I do the ptosis correction. For the ptosis, Usha has shown very nicely how to do with a frontal slit. But what I feel in blepharophimosis, the lids are very ptotic and they're little, very phimotic and they're little thick. So in such situation, I prefer using a fascia lata. So ptosis is the last stage. First, the epicanthus inversus and the hypertelorism. Secondly, a lateral canthoplasty along with the conjunctivoplasty. And third is a ptosis correction, which is a frontally slit, but fascia lata.
Thank you.
So, Harshul, you could start the
Yes,
next.
ma'am.
Dr. Hamid, you could get your slide sharing.
Yeah, so it's a pleasure to introduce Dr. Hamid, who is our next speaker, and he'll be speaking on evaluation of proptosis, which is a very relevant topic for our PGs. And he's currently the consultant in the Eye Foundation group of hospitals from Bangalore. He specializes in orbit oculoplasty in pediatric ophthalmology, and he has done his post-graduation and residency at AIMS, New Delhi. Dr. Hamid?
Thank you very much, sir, for the kind introduction. I'm very thankful to Dr. Chitra ma'am for giving me this opportunity to present in this webinar along with the experts in the field of oculoplasty. So I'll be talking about the evaluation of proptosis in brief. So proptosis is defined as a forward movement of the globe in relation to the skull, measured by protrusion of the apex of the cornea in front of the outer orbital rim. Outer orbital rim. So the normal values include 14 to 21 millimeter with an average of 16 millimeter. The value of more than 21 millimeter as an absolute reading or a difference of more than 2 millimeter is considered as significant. Before knowing about proptosis, we need to know what are the conditions that can mimic proptosis, which is called as pseudoproptosis. Like in this case, if there is an increase in the size of the globe, for example, unilateral high myopia or ophthalmos can present as pseudoproptosis. In the second example, you can see this is a case of a craniosynostosis in which you have a premature closure of the cranial sutures leading to shallow orbit, and it fails to accommodate the normal globe, causing proptosis. And in other cases like contralateral enophthalmos in post-traumatic blood fracture, you can present as a pseudoproptosis of the normal eye. And even in contralateral ptosis, you can have an ipsilateral upper lid retraction, which can mimic proptosis. So a complete and a precise history is very important to come to proper diagnosis. Most important is the age of onset of proptosis. For example, if the child is presenting with proptosis since birth, you need to consider in terms of congenital cystic eyeball, teratoma, or meningocele or encephalocele. Whereas coming to the course, whether the proptosis is rapidly progressive or is it slowly progressive? If you see a history with a rapidly progressing proptosis, you need to think in terms of infectious inflammatory pathology or a malignant tumor, or even in case of a pre-existing lymphatic malformation, you can have chocolate cyst presenting acutely. Then you need to ask about the associated symptoms of proptosis, like is it associated with pain? Again, which gives us a clue in terms of infectious and inflammatory pathology as well as malignant tumors. Sometimes even benign tumors can present with pain because of hemorrhage within the lesion. Then you ask about whether the vision is hampered or not. That indicates the compression of the optic nerve by the mass, or it can also indicate astigmatism induced by the mass directly indenting on the globe. Then you ask about whether the patient is having double vision as well as squint. That indicates thyroid ophthalmopathy or a mechanical obstruction of the globe because of the enlarging mass itself. Then you ask about whether the proptosis is increasing on bending forward or on straining. That indicates a vascular malformation. Then you ask about whether the proptosis is intermittent, again indicating a vascular malformation. Especially in children, you can ask whether the globe enlarges or if there is proptosis on crying, indicating a meningocele or encephalocele. Then you ask about the medical history, especially thyroid eye disease, since it is the most common cause of unilateral or bilateral proptosis in an adult. Then you ask about diabetes, very important. If you see an adult patient coming with acute proptosis, it can be a case of an invasive orbital mucormycosis in an uncontrolled diabetic patient. Then you ask about tuberculosis or any systemic cancer to rule out mets to the orbit. Then you ask about the family history of cancer and neurofibromatosis. Coming to the inspection, you need to look for the facial symmetry. Like for in this patient, you can see there's a fullness in the temporal fossa with narrowing of the horizontal aperture. This is a case of a this is a case of a dermoid cyst. And you can also come across fullness in the temporal fossa in cases of sphenoid wing meningioma and metastatic neuroblastoma. Then you look for the position of the globe. There are two views. One is Navziger's view, in which you ask the patient to sit on the chair and you go behind the patient and look the patient's eyes from above to look for the asymmetry. And then other way is the worm's view, in which you look at the patient's eyes from down to look for asymmetry. Axial proptosis is when the eye is displaced straight outwards along the anterior-posterior orbital axis. It is most commonly seen in thyroid ophthalmopathy and intracranial lesions such as cavernous hemangioma, optic meningioma, optic neuroglioma. Whereas abaxial proptosis is when the eye is pushed forward and also displaced off its central axis. It is commonly found in extracorneal tumors. Like for example, in this case, you can see there's an inferior temporal dystopia, which is mainly because of the lesions in the superior nasal quadrant, such as rhabdomyosarcoma, meningocele, encephalocele can present with inferior temporal dystopia. This is a case of an inferior dystopia, that is because of the lesion in the superior orbit. For example, you can have schwannoma or lymphoma presenting in this quadrant. Whereas inferior nasal dystopia is because of the lesion in the superior temporal quadrant. That's where we have the lacrimal gland. So any lesion of the lacrimal gland, be it benign, malignant, or inflammatory pathology, can present with inferior nasal dystopia. Then superior dystopia could be because of the lesion of the maxillary sinus, such as squamous cell carcinoma of the maxillary sinus, eroding into the orbit and pushing the globe up. Then you need to look for the periorbital fullness. Like in this example, you can see there's a fullness in the superior sulcus, indicating a mass in the superior orbit displacing the globe downwards. Then you look for the skin changes. And this example, you can see that the skin is very tense, shiny, and red, indicating an infectious pathology like orbital cellulitis. Or you can find yellowish discoloration of the skin in xanthogranuloma. The tumor surface, we look for the prominent vessels, whether you can see whether the tumor is smooth, or you can see multinodularity of the lesion in case of recurrent pleomorphic adenoma, or if it is a rapidly progressing malignant lesion, can also present with bleeding or ulcer. And you should look for the dilated tortuous vessels over the mass as well. Valsalva maneuver is important in case of especially high flow vascular malformation and orbital varix. You ask the patient to close the nose and the mouth, and or you can ask the patient to bend forward and measure the size of the lesion, or you can measure the amount of proptosis before and after Valsalva maneuver to look for any change. This is a case of a pulsatile proptosis. You can see the patient is also having multiple neurofibromas on the skin. It is a case of a neurofibromatosis with a sphenoid ring dysplasia leading to transmitted pulsation into the globe, causing pulsatile proptosis. Pulsatile proptosis is also seen in cases of high flow keratoconus fistula. Then very rarely you may come across something called as chewing oscillopsia. This is a case of a dumbbell dermoid in which you can see there's an extraorbital component as well as intraorbital component. Whenever the patient is chewing, there's a contraction of the temporalis muscle pushing the extraorbital component into the intraorbital component and causing chewing oscillopsia. Chewing oscillopsia can also be seen in extensive removal of lateral orbital wall as well. Then in the eyelid, very important to look for the signs of thyroid eye disease, since it is the most common cause of proptosis in adults. We look for the signs of lid lag, lid retraction, or lateral flare. In a case of a neurofibromatosis or lacrimal gland lesions, you can come across an S-shaped deformity of the upper eyelid. Or if it is a very long-standing lesion, you can see increase in the vertical lid height as well. And in some cases, like metastatic neuroblastoma, you can have recurrent ecchymosis of the eyelid as well. Extraocular movements, very, very important. So, for example, in this case, you can see there's cysticercosis of the superior rectus LPS complex leading to limitation of elevation. Extraocular movement will be restricted even in case of thyroid eye disease or any mechanical obstruction to the movement of the eyeball by an enlarging mass, or direct compression of the cranial nerves can also cause extraocular movement restriction. Conjunctival or fornical examination, and this you can see a bluish discoloration of the superior fornix indicating an underlying vascular malformation, or you can come across a solid chemosis in the case of a metastatic neuroblastoma, or you can come across something like purplish reddish lesion in the superior fornix seen in orbital varix, or you can see in an elderly patient with a pinkish mass in the inferior fornix indicating lymphoma. And also you should carefully look for dilated tortuous corkscrew vessels in the conjunctiva, which is seen in high flow keratoconcavenous fistula, or chemosis in a case of rapidly expanding tumor or a chocolate cyst in a lymphangioma. Exophthalmometry is very, very important. It measures in an anterior-posterior plane the distance between the apex of the cornea and a bony point. It is usually taken to be the deepest portion of the lateral orbital margin with the eye looking straight ahead. There are usually three types, which is absolute exophthalmometry, in which the amount of proptosis is compared to a normal standardized value. Comparative proptosis, in which the amount of proptosis is measured in the same eye compared from time to time. And relative exophthalmometry, in which the amount of proptosis is compared between the two eyes. Hertel's exophthalmometer is the most commonly used instrument to measure the amount of proptosis. In this, the patient and the examiner should be at the same level. You ask the patient to close the eye and locate the orbital notch on the temporal side of both the orbit. The separation, so basically the Hertel's exophthalmometer has two foot plates. One is fixed, the other one is sliding. So the separation of these two should be kept constant in subsequent visits to avoid errors. Then you have two red lines on the exophthalmometer. It should be in line with each other to avoid parallax. Then vertical displacement is measured by using two scale method, in which a horizontal scale is placed along the lateral canthus of two orbits, and a vertical scale is used to measure the distance from the horizontal scale to the 6 o'clock limbus, and you take the difference of the two eyes. That will give you the amount of vertical displacement. Whereas horizontal displacement, you take a mark on the center of the nasal bridge and you measure the distance from that mark to the nasal limbus of each eye, and the difference between the two measurements will give you the amount of horizontal displacement. Then you have Lutz exophthalmometry. It's a simple single transparent plastic ruler which is having reading on both the sides to avoid parallax. It has 0 to 40 millimeter reading. It's very useful, especially in children. They will not get intimidated by this since it's a very simple plastic ruler. Then you have Nogel's exophthalmometry. It is slightly different from Hertel's exophthalmometer. It rests on the superior as well as inferior orbital rims. It doesn't require lateral orbital rim, so it can be used in cases where there is fracture of the lateral wall of the orbit, and it also measures globe dystopia along with axial proptosis. So palpation, you start with the orbital rim to look for any deformity. Then you relax the orbital septum by asking the patient to look up and feel for any mass. You locate the mass and measure the extent and look for the border of the mass. Look whether the mass is fixed to the underlying bone. Look for local rise of temperature or tenderness, which can indicate an infectious or inflammatory pathology. Look whether the surface is smooth or nodular. Consistency, whether it is firm, soft, or hard. Look for any deformity of the surrounding bone indicating erosion because of the rapidly progressing tumor. Then you do a retropulsion test in which you ask the patient to close both the eyes and you use your thumb to push the globe gently backwards and look for whether the lesion within the orbit is compressible or not. Then you look for the pulsations of the tumor or on the globe. You can find pulsations in AV malformation, or if there is any bony defect in case of neurofibromatosis, like an absence of sphenoid wing meningioma. Then auscultation again will help us to find out keratocavernous fistula, in which you can hear bruit over the eyeball or over the bone. Other very important examination in the case of a proptosis is measuring the visual acuity. So visual acuity can be hampered because of astigmatism due to direct indentation of the globe by the mass. It can be because of optic nerve compression. It can be because of a central retinal vein occlusion or central retinal artery occlusion, or even exposure keratopathy because of massive proptosis can cause diminution of vision. Pupil reaction again indicates optic nerve compression if you find RAPD. Then cornea examination to look for exposure keratopathy. Carefully examine the iris to look for lesion nodules that is seen in neurofibromatosis again. Then fundus examination is important, especially in the case of an optic nerve sheath meningioma. You can come across optociliary shunt vessels, or in any intracorneal tumors which is directly compressing the optic nerve can present with disc edema or CRUO. Or if the mass is indenting on the globe, you can find chorioretinal folds as well. So color vision, contrast vision, and visual field is very, very important, especially if the patient's vision is normal and you are suspecting any optic nerve compression. These three will help us in documenting preoperatively, and then diplopia charting and Hess charting to document the extraocular motility as well as double vision. Systemic examination, especially in the case of a neurofibromatosis, we look for other signs like cafe-au-lait spots. Lymph node examination you must do in the case of a malignant tumor to rule out local spread, and you look for generalized lymphadenopathy in the case of a lymphoma. Respiratory system examination is important to rule out CA lung. Abdominal examination is important if you are suspecting mets from neuroblastoma. Coming to investigation, the commonly done investigation are the CT scan, ultrasound, and MRI scan. So an axial sagittal coronal cuts of orbit, head, and paranasal sinuses are very essential for evaluating the exact location, extent of the lesion, and also planning for the surgery. So CT scan will give us a relationship between the orbital mass and the surrounding bones, whether there is any erosion or defect within the bone. It will give us a relation between the orbital mass and the optic nerve, whether the mass is medial to the optic nerve or lateral to the optic nerve to decide on the plan. And also it gives a relationship between the paranasals, and sometimes we have lesions arising from the paranasal sinuses and eroding into the orbit. And also we can come to know whether the lesion is encapsulated, well-defined, and circumscribed, and which can be easily resectable. Or if it is diffuse, you need to do debulking or incision biopsy. Contrast again will give us an information about the vascularity, whether it is highly vascular. If it is highly vascular, you need to prepare blood transfusion as well in that case. Ultrasonography is a good adjunct to CT scan. So this will give information about whether the lesion is solid or cystic, whether it is heterogeneous or homogeneous. Like in this case, lymphangioma, you can see macrocysts with septae in between. And MRI finally is very, very important if you are looking for a lesion within the orbital apex, or if it is an optic nerve tumor like optic nerve glioma or optic nerve meningioma. This will give a better information than a CT scan. So then you have incisional or excisional biopsy that will help us in diagnostic circumstances. Then FNAC is also an important diagnostic test, but you should know when to avoid, like pleomorphic adenoma, hydatid cyst, or a Damart cyst. Peripheral blood smear again is very important in children to rule out leukemia. And there are other tests that you need to do, like thyroid function test or other markers to rule out systemic granulomatous diseases as well. Thank you.
Thank you very much, Dr. Hamid. We'll go on to the next speaker because we're running quite late and you have a lot of great speakers on the anvil. Dr. Santosh Honawar is our next eminent speaker who's going to be dwelling on orbitotomy. Dr. Santosh is very well known, a prolific figure, medical director of CFS Hyderabad, an editor of IGO in his second term. He has brought the most admirable and awe-inspiring trajectory in IGO, its peaking impact factor and enhanced patronage, a surgeon par excellence, innovative and a genius. His postgraduate teaching program is what I would particularly like to refer to, the iFocus, which has raised the platform of learning for the postgraduates to the highest unbeatable standards. And it goes without saying that this brilliant individual has had his own endless list of trophies and gold medals along his career path. On to you, Dr. Santosh.
Thank you, Chitra. Am I audible?
Yes.
Okay. Chitra is the dynamic and innovative chairperson of ARC. Thank you, Chitra, for thinking of oculoplasty, which constitutes about 30 to 40% of your main cases in the exam and also the main questions. And the dynamic members of the ARC, thank you all. I'll be talking about surgical approaches to the orbit. Hamid had very comprehensively covered the evaluation of orbit, and that is actually the baseline for doing surgery. And orbit is known to be a Pandora's box full of evil. That's because more than 50% of all orbital tumors are malignant and are potentially life-threatening. So when you manage orbital tumors, when you do orbitotomy, it is imperative that you combine your surgical skills with oncological principles. This is what the previous speaker had covered. When you have a patient with orbital tumor in front of you, you have to kind of understand what is it likely to be. Is it a tumor, inflammation, or something else? Where is it located? Intracoronal, extracoronal, has intracranial extension, etc. What are its relationships? Is it related to extraocular muscles and the optic nerve? Is it operable at all or not by me? Or would I need the help of a neurosurgeon or an ENT surgeon? What approach do I envisage and what to expect? Do I want to completely remove it? Would I do an incisional biopsy? Or what complications would I counsel the patient for? So you have to follow a logical stepwise approach, starting from clinical history to regional examination, systemic examination, appropriate imaging, then specific investigation, and then surgery. So you cannot simply jump to surgery in a given case. You have to logically follow all these steps. And surgery is not the end. You have to give due interest to histopathology, and that will decide the course of further management, such as adjuvant treatment. So when you follow this logical step, there are certain situations when you say absolute no to surgery, you will not do surgery. There are certain situations when you say emphatic yes to surgery, you will do surgery. And there are some gray areas where you may do surgery depending on the indication. Example is this child with bilateral proptosis with temporal fossa fullness, very typical metastatic films, no surgery here. Similar situation, but with periocular ecchymosis or raccoon eye side, triradiate lesion centered in the sphenoid wing. Again, no surgery here, child goes to a pediatric nephrologist. Child with proptosis of the left eye with subconjunctival hemorrhage and rod spots in the fundus. The only test that you would do is not CT or MRI, but a peripheral blood smear to confirm that it is AML and send the child over to a pediatric hemato-oncologist. There are indications for FNAC for a lesion, which is a soft tissue lesion, which is in a patient with a prior known history of multiple myeloma. If you were to develop such a lesion, then you would possibly do just a fine needle aspiration cytology, not do an orbitotomy to confirm that it is plasmacytoma and send the patient over to an oncologist. What are the non-surgical approaches? This patient doesn't seem to have proptosis at all. He's a pilot. He's been failed in a recent medical exam, and that's because he has a tumor right at the orbital apex impinging on the optic nerve and the superior orbital fissure. And that has caused his visual field defect. How do you deal with it? Well, of course, by the MRI characteristics, it's clear that it is a cavernous hemangioma, which is a surgeon's delight. But if you were to meddle in the superior orbital fissure area, possibly you'll be left with some diplopia, patient will be left with some diplopia, or there might be further chance of deterioration of vision. So you choose an alternative modality here, and that could be stereotactic radiation, with which you can see that his visual field has returned to normal and the tumor has much shrunken in size. So to be very categorical as to when you would do surgery and when you would not want to do surgery. In the literature, similar patients have been treated with gamma knife irradiation with exactly similar results. So if you have a patient with tumor impinging on the superior orbital fissure and the orbital apex, even if it's well circumscribed, you may not want to do surgery and consider alternative modalities, because such are these patients where complications are the highest. The second category of management would include injections. Patients with orbital lymphangioma, a young lady with mild proptosis, she only wants cosmesis for her proptosis, and also she wants to get rid of these multiple episodes of increase in proptosis whenever she has a URI, etc., comes for surgery. Would you want to do surgery here? Look at the tumor. It is so diffuse. It's involving the medial rectors, lateral rectors, lacrimal gland, SRLPS complex, and it's all around the optic nerve. Whichever you may approach from, say, supromedial, supralateral, wherever you may go into, excise or debulk this tumor, you have a possibility of having complications. She has no functional problem at all. There you would choose an injection. Injection Picibanil did the job here. 3 injections of Picibanil, and you can see that the intraconal space is well cleared and she has gotten the cosmesis that she wanted. She has symmetry in both eyes now. So that was Picibanil. And if it's a macrocystic lymphangioma, you aspirate the content, that is blood, and inject a drug, either Picibanil or bleomycin, with very good results. Bleomycin is a very good drug in the absence of Picibanil, which is not very commonly available. It's used in the dose of 1 international unit per ml, and doxycycline is coming up in the dose of 10 milligram per ml. Also is the use of Tisilu. All these drugs have to be very conservatively injected when the lesion is in the intraconal space, because there might be complications. One more patient with injection of bleomycin, one more similar patient with injection of bleomycin. So drugs such as these work very well, injectables in lymphangioma. Now, what about a patient who is suspected to have eosinophilic granuloma, where the lesion is involving the dura there? Of course, curettage is the treatment of choice, but the complications of curettage in these patients are quite significant because the tumor is involving the dura. And in these patients, we do a very safe biopsy from the middle of the lesion, not go anywhere close to the dura, confirm the diagnosis intraoperatively using frozen section methods, and then under visualization, inject a steroid, that is triamcinolone, right into the lesion, and over a period of 6 months, you can see bone actually very nicely remodeling without any complications. So these are some of the indications for injections. This is one more patient with eosinophilic granuloma, much resolved with 1 injection of triamcinolone. The next category is incisional biopsy. Whenever we suspect a malignant tumor where the lesion is poorly localized and infiltrative, where complete excision may cause functional problems, or if the lesion is associated with crucial structures, thus making a complete excision critical in terms of complications, then or for intraoperative diagnosis, you do an incisional biopsy. But the method of doing biopsy is very important, because 8 to 20% of orbital biopsies result in misleading or non-specific diagnosis, mainly because of poor sampling. Now, this is a patient who has a superior orbital lesion, a young child, a 6-year-old child. We always do biopsy from 3 layers and send to the pathologist. In the superficial biopsy of this patient, this was done from this aspect. You see predominant fibrosis and inflammation. Suppose I were to restrict the biopsy to only this area, then my diagnosis in this child would be orbital inflammation. In the mid zone and the deep zone, we found the tumor, which was embryonal rhabdomyosarcoma. So if you do a unrepresentative biopsy or do just a superficial biopsy, then you may miss the diagnosis. This is a patient, young adult with bilateral proptosis with a lesion which is extending both to the right as well as the left orbit, and paranasal sinus involvement, where superficial biopsy again showed inflammation and fibrosis. This is tissue reaction, and the deep biopsy showed granulomatous inflammation, and GMS stain showed fungal granuloma. So whenever you plan a biopsy, you have to do a layered biopsy from the periphery, mid-zone, and go to the core or the epicenter and estimate the depth based on CT and MRI, and that will make your incisional biopsy diagnostic. The last bit is about excisional biopsy, which is actual orbitotomy. This can be done for either benign or malignant tumors, which are well localized and circumscribed. So this is the key word. If the lesion, whether it is benign, malignant, or whatever it may be clinically or radiologically, as long as it is well localized and circumscribed, non-infiltrative, not associated with critical structures, then you would want to do an excisional biopsy, because you don't want to get into the orbit again in such circumstances, because these are least complicated surgeries, well circumscribed lesions which are not associated with critical structures. Now, surgical approaches are neurosurgical or endonasal, which are not in our realm. But when it comes to orbital approach itself, depending on the location of the tumor, anterior, mid-orbit, or deep orbit, you have transcutaneous, transconjunctival, and combined. Coronal, I would leave out. Now, anterior orbitotomy, transcutaneous, these are the incisions that we have. One is Lynch incision, which is a supromedial incision. This is a typical ENT incision, but it's been modified to make it smaller. This is sometimes useful in extremely medial lesions which are around the trochlea. If you don't want to disturb the trochlea and go from that approach, it is perfectly all right. It will not leave a very ghastly scar. Then you can do a vertical lid split incision, split the lid vertically like that, iatrogenic lid laceration you create, and go right into the supranasal fornix. This is a very useful incision if you again don't want to disturb the trochlea and the supraorbital nerve. Very rarely used, but it is a useful incision. Then upper eyelid crease incision, whichever the location, it could be medial, it could be central, or it could be central to lateral with a lateral flare. That is called Harris incision or upper eyelid crease incision. You may want to know the names because some of these names are asked in the exam. And the subbrow incision, B for Benedict. Subbrow incision goes by the name of Benedict. In inferior, you have subciliary incision, which is right under the lashes, or a lower eyelid crease incision, which goes by the name of Davis. This is a typical modified Lynch incision. It need not be as inferior as this. It could be just restricted to this small incision, and rest of the dissection can be subcutaneous. This is a patient with orbital lymphangioma earlier, where bleomycin was not available. We had debulked it by using a vertical lid split incision. Now, eyelid crease incision is a very versatile incision. It can be used for lesions such as dermoids. It can also be used for preseptal lesions. So whenever you talk about eyelid crease incision, it is just an incision, but the approach could be either preseptal or posterior to the Whitnell's ligament. When the lesion is posterior to the Whitnell's ligament, it is not logical to cut the Whitnell's ligament. Although this particular approach has been described, whenever a lesion is posterior to the Whitnell's, you do what is called a trans-arcus approach. You go to the arcus marginalis and come forward from there rather than splitting the Whitnell's as is shown in this picture. And the same lid crease incision can be used for lateral orbitotomies, combining it what is called a marginotomy or removal of the overhanging bone. So this particular incision is extremely good for anterior orbitotomy. This is the Benedict incision, which is right in the middle of the orbit. Now, these are the lower eyelid crease incision. This is slightly in the lower lid crease, but if you can do it right under the lashes, pretracheal incision and lower lid crease incision. When we talk about conjunctival approaches, again, there are names to remember. Medial perilimbal goes by the name of Galbraith and Sullivan. There is lateral perilimbal. These are transconjunctival incision. These are not very commonly used. Transcaruncular incision goes by the name of Balk and Goldberg. Lateral canthal incision, again, not very commonly used. Inferior fornacial incision, this is most commonly used with a canthotomy, and inferior cantholysis goes by the name of McCord-Moses. This is the most versatile incision for transconjunctival approach. Inferior fornacial with transcaruncular. That means the same incision can extend transcaruncular as well, doing a panoramic, giving you a panoramic view. This is a minimal access orbitotomy. Like this child who has an orbital teratoma, you can see a tooth within it, confirming the radiological diagnosis, but the tumor was extending on both sides of the optic nerve, lateral as well as medial. So we use this transconjunctival incision here with a lateral canthotomy and cantholysis. That's the lateral cystic component of the tumor. And that pearly white structure that you see there is the optic nerve and the medial solid tumor. So you can actually see the nerve and dissect around it without touching it using a surgical microscope. And that's the complete tumor resected. And that was the groove for the optic nerve. So this kind of approach gives you a very good view of the entire tumor and the crucial structures that are involved, and the results are pretty good. This is a young lady with a deep orbital cavernous hemangioma, and this is a typical transconjunctival orbitotomy, the video of which I'm going to show. where you make a small lateral canthotomy about 5 to 7 millimeter and do a inferior cantholysis. That's the inferior cantholysis. Inferior cantholysis loosens the lower lid. This is optional. And then you make an inferior fornicial incision. It's not actually fornicial, just short of the fornix, about 4 millimeter from the lower edge of the tarsus all across. Retract all the tissues, ledge a spatula on the lower eyelid margin, and then go right to the lower eyelid margin without disturbing any other tissue. Then make an incision, a bold incision at the lower eyelid, lower orbital margin into the periosteum. Dissect the periosteum until we reach the inferior orbital fissure, apex of the inferior orbital fissure, or visualize the infraorbital nerve. Beyond that, there is no logic in extending the periosteal dissection because you'll be damaging those structures. Before you proceed further, at every step you have to achieve hemostasis, and that could be by either a cautery or a fulguration device, or sometimes you even need a bone cement. Now you make a periosteal incision in the quadrant where the tumor is located. That's the periosteal incision, which is crescentric incision. Retract orbital fat using retractors, and then dissect the tumor to about 60 to 70% of its surface before you apply cryoprobe. Cryo is like the third hand for the orbitotomy surgeons. It gives you a good purchase of the tumor with which you can very gently rock out the tumor. And as the tumor comes out, you have to look at the posterior vascular pedicle, which needs to be cauterized. Otherwise, patient will have a secondary bleeding. And then all you need to do is wait for hemostasis to happen, close your lateral canthotomy and inferior cantholysis, and do fornicial suturing. This patient, after about 10 days following surgery, has no stigma of a heavy orbitotomy. She looks good, and that is the very purpose of this incision, a hidden incision, safe incision with minimal trauma. All these patients have been operated by inferior fornicial approach with good results. Now, lateral orbitotomy was described in 1888, as long ago as 1888. It was the Cronlin's lateral orbitotomy. Between 1888 and 1954, there was no development at all. That's a very typical Cronlin approach. It is against the contour of the orbit. In fact, that was to raise a skin muscle flap and a bone flap to get into the lateral orbit, cutting the bone from the lateral side. And that is how it used to be done. Berkey modified it, and all that he modified was the incision. He made a large lateral canthotomy with a V or a Y split of the upper lid and the lower lid. So that is how it was until stellarderite incision came in, which is a lazy S-shaped incision. You probably need to remember these names. Stellarderite incision was used for a very long time. In the 60s, 70s, 80s, even 90s and early 2000s, this was a very popular incision. Then came eyelid crease incision. That was a very simple modification. Eyelid crease incision is just this. So instead of going right under the brow, you can go through the eyelid. Takes a bit of time to go suborbicularis and make a good dissection. It's a very good incision. But whenever you have a malignant tumor, you don't want to do eyelid crease incision because of the fear of seeding and planning postoperative radiation. That is marking the skin incision. That's a eyelid crease incision. And whenever there is a tumor in the intraconal space or extraconal space related to extraocular muscles, you tag the respective muscles and use either a monopolar RF electrode or a Bartbacher knife to make that skin orbicularis incision. Then orbicularis is dissected. Aim is to reach the superior or superotemporal orbital margin as quickly as possible without traumatizing any tissue and without opening the orbital septum. So your dissection is mainly suborbicularis when you make a lid crease incision. Then you make a periosteal incision. This is standard. Irrespective of the incision that you make, rest of the surgery is almost the standard. Periosteal incision about 3 to 4 millimeter from the orbital margin. And you go right to the junction of the lateral orbital wall and the floor of the orbit. Then periosteum is dissected. Sometimes it is very tightly adherent to the bone depending on the pathology. And you dissect the periosteum till you reach the arcus marginalis. Then you get into the periorbita, which is very gently dissected without causing any premature rip in the periorbita. And when you go laterally, you have to be careful of the periosteum at the frontozygomatic suture and also visualize the temporal blood vessels and the nerves, zygomatico-temporal and zygomatico-facial. So that was the approach. And then once you've done that, You can do orbitotomy without a bone cut or with a bone cut. So this particular video will show orbitotomy with a marginotomy. So the initial steps are the same, but here I'm doing a supratemporal skin incision right under the brow because this was a suspected malignant tumor. This had grown a lot. This was a lacrimal gland tumor. So whenever you're suspecting a malignant tumor, you have to approach it directly without doing a kind of a remote incision. Basically, you don't want to seed the tissues with malignant tumor. Radiation becomes very difficult to plan. So rest of the steps are the same. I'll forward it a bit. Periosteal dissection. Periosteum investing the tumor is also dissected. Then you clear the periosteum just a bit on the supratemporal aspect to bring in what is called marginotomy. This was described by Dr. Goldberg, where that sharp rim of the supratemporal orbit can be removed. Now you don't really need a bone cut. When you do this, you get good view of the posterior orbit. Then you pass sutures through the superficial tissues, make an incision in the periorbita. And whenever you do that, you don't injure the capsule of the tumor. Surgery is performed under microscope for good visualization and also elimination. Very gentle periosteal dissection and a T incision in the periosteum. Then hold edges of the vertical periosteal incision and drip to make a T into a V window. Then you don't hold the tumor, but hold the periosteum around the tumor and dissect the tumor with blunt tipped instruments. And as you dissect, you might find more adhesions. If it's a vascular pedicle, you cauterize. If it's a fibrous band, then you cut it. So those are vascular pedicles, those were cauterized. And you ballot the tumor and see if there is any more adhesion. There seems to be some amount of restriction on the medial side. So we go back and look at the medial side. There's a fibrous band that needs to be dissected. And then finally, when there is no further resistance, the tumor is ready to come out. You apply a cryoprobe and hold it till there is a good ice ball formation, and then gently rock the tumor out, estimating wherever there's an adhesion, you go back and dissect it under visualization. Then finally, you have to support the tumor from the posterior aspect and take it out. And as you do that, if you find a vascular pedicle on the posterior aspect, might as well cauterize it and remove the tumor to prevent post-operative or further intraoperative bleeding. So that's very important to visualize the vascular channels that are supplying the tumor. So patience is the key here. Whenever you remove the tumor, that's how it looks. And finally, you need to suture it up. So I would skip this video. That's about not cutting the bone. So earlier we were cutting the bone, now we don't cut the bone. So what next after surgery? So far is so good, surgery is fine, but after that what you do is most important, I believe, because histopathology guided adjuvant therapy, if you don't do and leave the patient with just the diagnosis, then you're doing more harm to the patient. Examples are some of these adenoid cystic carcinoma, or abdominal sarcoma, or a solitary fibrous tumor, where if you get that diagnosis, then you have to plan your radiation well. Planning radiation is important for you to participate in it, because for example, in adenoid cystic carcinoma, radiation, if you just send it for radiation, then the radiation oncologist may give radiation anywhere in the orbit. But the goal is not that. Since it's a neurotrophic tumor, your radiation field should be extended field. It should include superior orbital fissure, inferior orbital fissure, temporal fossa, entire orbit plus 10 millimeter margin. And you have to specify that for the radiation oncologist to know. In patients who have adenoid cystic carcinoma, again, you do what is called multimodal treatment. That means to shrink the tumor with pre-operative chemotherapy, and then you do a excision without cutting the bone, en bloc excision, and finally you deliver radiation and adjuvant therapy. So this bone need not be excised at all. This destroyed bone actually remodels over a period of time. So in conclusion, I would say that logical approach to orbital tumors, beginning with a good clinico-radiological diagnosis, planned surgical approach, and histopathology guided systemic therapy maximizes the outcome. Thank you so much.
Thank you very much, Dr. Santosh, for your brilliant talk. I'm sure each of the talks have been so good this far. I do hope the PGs have been locked on to the webinar. Our next speaker is none other than Dr. Ashok Grover, an amazing leader of ophthalmology, President of Oculoplasty Society of South Asia, past President AIOS, past President Asia Pacific Society of Oculoplasty and Reconstructive Surgery, and Oculoplastic Association of India, a Padma Shri to top it all, and Chairman of Vision Eye Centers in New Delhi and Chairman Department of Ophthalmology of Gangaram Hospital, New Delhi. He would be talking on management of thyroid eye disease, and I'm sure you would have all your answers as he carries on with his talk. Thank you. On to you, Dr. Ashok.
Thank you, Dr. Chitra. I hope I'm audible.
Yes, yes.
So I'll be taking you through the thyroid eye disease with the carry-home points that a postgraduate needs. So the points that I'll be discussing is what really does a thyroid eye disease mean? What are the most important factors in its pathogenesis? What is the epidemiology? What do you need to know about the signs and symptoms? What investigations do you carry out? What are the current classifications? What is the non-surgical and the surgical management? So we'll go through them very briefly. So thyroid eye disease is a sight-threatening as well as disfiguring autoimmune inflammatory disorder affecting the orbit and the periorbital tissues, characterized by these characteristic findings, which we will be talking about. Now, pathogenesis is important because this is important in all the newer therapeutic approaches that are coming up as targeted therapy. So you need to know that essentially the orbital fibroblasts, which have the potential for differentiation both into adipocytes and myofibroblasts, which express these receptors, the insulin-like growth factor 1 receptor and the TSH receptor, because these are the circulating factors which are responsible for the thyroid disorder, and they are also responsible for the thyroid eye disease. Now, once these receptors are stimulated, there is an activation which leads to recruitment of the T and B lymphocytes and macrophages, with upregulation of the cytokines, which are important in the pathogenesis, along with the augmentation of glycosaminoglycans. Now, these depositions lead to new adipogenesis as well as fibrosis, which result in extraocular muscle enlargement as well as the physical expansion of orbital fat. Now, this is the picture from Dr. Santosh Honavar's editorial in the August issue, and you must look closely at it. So we were talking about the orbital fibroblasts with expression of TSH receptors and insulin-like growth factor 1 receptors, which are stimulated and which result in the T cells, B cells, and macrophages being stimulated, release of cytokines, and the result is myofibroblasts and adipocytes and glycosaminoglycans, leading to the characteristic orbital changes. And this also shows you where our targeted therapy or the biologics are acting in this entire cycle. So let's look at how important this disease is. Now, this disease would affect people generally between 30 to 60 years of age. We've had some very nice data in this issue of Indian Journal. And one of those articles shows that the average age in Indians is about 40 years, which is in the same range, somewhere between 30 and 60. Females are more likely to develop thyroid eye disease, as we all know. But this figure is much lower in Indians, 1.1 to 1, as compared to Caucasians, where it is 4:1. Now, thyroid eye disease is a very common disease, which includes hypo and hyperthyroid, hypothyroidism being much more common, with 42 million people in India having thyroid disease. And in hyperthyroidism particularly, how common is prevalence of the thyroid eye disease? Now, the Caucasians show an expression of thyroid eye disease in about 40%. Europeans, a similar figure, which is again Caucasians. Whereas some figures suggested that in Asians, the figure is as low as 7.7%, but some other studies showed from the epidemiological studies that the figure may be as high as 35%. So how commonly do you get sight-threatening disease in thyroid eye disease? Now, this figure may possibly be lower in India, and that is why the interventions that we need are possibly lesser than those in Caucasians. The UGO-GO study had 28% of thyroid eye disease patients having sight-threatening disease, whereas the figures in India suggest somewhere between 2 and 7.5%. Now, what is the clinical course that a thyroid eye disease takes? You've all heard of the Rundle's curve, which is a characteristic representation of the disease, which shows an increase, then goes into a plateau, and then comes down, but does not come to the basal level. Now, this phase of inflammation would be variable, anything between 6 and 18 months, but all cases do not follow a characteristic pattern. The symptoms may be redness, irritation, decreased vision, bulging of the eye, double vision, pain, or loss of visual field. And the signs, the most common ones are exophthalmos, extraocular motility restriction. We'll talk about this in greater detail later. The eyelid signs, many of which you need to remember the names. Some of the examiners may be very fond of them. The conjunctival and corneal signs, corneal exposure, conjunctival congestion, lid edema, and of course, retraction and all those characteristic signs. Optic neuropathy can be particularly important because of the visual loss, and so are the exposure keratopathy. And rise of intraocular pressure also can be quite common. All of these may together be present only in about 5% of the cases. Now, proptosis may be either unilateral or bilateral, but bilaterality is much more common, approaching 97% in studies, and is classically axial. Extraocular motility restrictions are present in 1/3 to 1/2 of the cases because of the various changes of swelling and fibrosis. But what need to remember is that inferior rectus is the most commonly involved muscle, followed by medial rectus. Eyelid retraction is a very characteristic sign, with the temporal flare being quite characteristic. There may be eyelid swelling, eyelid erythema, and a characteristic lid lag. In conjunctival and particularly caruncular congestion may be quite typical. Exposure keratopathy can frequently occur, and this may go on to progress to ulceration. Optic neuropathy, or the compressive optic neuropathy of the thyroid eye disease, is particularly important, which you must look for by monitoring all these signs which suggest optic nerve function on each visit, including visual fields. And this is characteristically caused by the crowding of extraocular muscles near the apex. An early diagnosis by the monitoring is important to start therapy. The ocular hypertension occurs because of elevated episcleral venous pressure, as well as due to restrictive myopathy and increased mucopolysaccharides in the orbit, particularly in the aqueous outflow systems. So you need to do all these examinations, including exophthalmometry, look for all signs of activity, and do monitoring of the function and motility of optic nerve. And imaging is important because extraocular muscles thickening and the type of changes, whether they are predominantly fat or predominantly muscle changes, also need to be assessed. You need to know about the characteristic thickening where there is a tendinous sparing in these cases. So you can have a muscle predominant or a fat predominant exophthalmos. And apical crowding is something that you particularly need to look for. Now, classifications, the classic no specs classification is a mnemonic which we were all familiar with as undergraduates, given by Werner, but this is no longer so functionally important, although you do need to know all the components involved in the no specs classification. What is most important and most commonly used in many clinics across the world is the clinical activity score described by Moritz et al., because it gives you whether a patient may be classified as active or inactive, and it's a very simple system. Now, there are these 10 points which you need to look for, and generally these 7 are the modified ones which you need to particularly talk about: the spontaneous retrobulbar pain, pain on eye movements, eyelid erythema, conjunctival injection, chemosis, swelling of the caruncle, and eyelid edema or fullness. So if you have a score of more than 3, then it is an active disease. And this is what you should be documenting. Now, visa classification is also used quite commonly, where it is based on a vision, inflammation score, strabismus score, and appearance score. But the UGOGO classification is important because it has a lot of importance in clinical management. It characterizes the disease as mild when the parameters of eyelid retraction, soft tissue involvement, or proptosis are minimal and there is no diplopia and or corneal exposure, which is simple and responsive to lubrication. But it becomes moderate to severe if these limits are exceeded and there is a diplopia. And it becomes sight-threatening when there is an optic neuropathy or corneal breakdown. Now, this classification is followed very commonly because this characterization into these 3 groups is important for management. So let's look at the management now. The medical management is important. Control of thyroid status possibly being one of the important things which you would do, but smoking cessation has been shown to be important. Selenium orally is also considered as a therapy. Radioactive iodine as a therapy for thyroid eye disease may have a role in precipitating the disease. You need to know about this. You need to know about the role of steroids. You need to know about the role of radiation and immunosuppressors and biologics. And we'll very briefly talk about them. Ocular management, mainly in form of lubricants, taping, and altered head position, may be important. Smoking cessation has been shown by several studies to be important, and this must be one of the first advices you give to your patients. For corticosteroids, it is now more or less a consensus that IV therapy is more effective than oral therapy and possibly would lead to lesser side effects, and it leads to medical decompression, and which is of vital importance. So it is used both for compressive optic neuropathy and moderate to severe disease where your purpose is to minimize the final loss that is left to the patient. The characteristic dosage protocols of UGOGO, which are commonly used, are these, but there are several other protocols. If you remember these may be more than sufficient for you. For the optic neuropathy, the characteristic dose is 0.5 to 1 gram for 3 consecutive days or alternate day for 2 weeks. For active disease, moderate or severe, you would use 0.5 gram weekly for 6 weeks and then 0.25 gram weekly for 6 weeks. And what has been found to be important is that if you exceed the dose of 8 grams you increase the complications which threaten the life of the patient. So you would generally make sure that you confine the dosage to less than 8 grams. And the study showed that the dose which is on the higher side has the greatest positive response. Orbital irradiation is indicated in active disease with severe thyroid eye disease and has been shown to have a positive response. And some of the protocols that are followed is the standard protocol of 20 gray in 10 days, or a reduced dose protocol of 10 gray over 2 weeks, or a low dose protocol where 20 gray is used over 20 weeks. And a fairly good safety has been shown with the current protocols. The biologics are increasingly coming to the fore in the management, and various biologics have been used, including rituximab, TNF-alpha inhibitors, but teprotumumab may have a game-changing role. It has been shown to be important in reducing the all of thyroid. Already received an FDA approval. The limiting factor is the extremely huge cost, and that is why it would take a while before it can be used more widely. So the indications for surgery are corneal exposure, which is not responding, or a sight-threatening optic nerve compression. However, expanding indications include a congestive orbitopathy, which is not responding, or aesthetic indications, which are increasingly used now, and they are important because it has a profound effect on the life of the patient. So as we said, your approach would be decided by whether this disease is predominantly due to increased orbital fat or due to enlarged extraocular muscles. And therefore, your strategy may change from fat removal to predominantly bone removal. So that is the customization that you carry out. Isolated fat decompression can be useful in some cases, and a reduction of almost 1 millimeter per milliliter of fat removed can be carried out in those where there is a predominant fat disease. In the muscle predominant disease, you need to do a lot more bony decompression. And for mild to moderate exophthalmos, fat and deep lateral wall decompression is the preferred strategy with very little possibility of any side effects and gives excellent results. We'll skip this part. Where the severe disease is concerned, you may add more walls. In addition to fat, you may do a lateral and medial wall, the so-called balanced approach. And for even more severe cases, you may need to add floor decompression, and you, however, compromise with an increased risk of producing new diplopia. So there is a sequential wall decompression approach which Dolman points out, orbital fat being considered as the first wall, and you gradually add the second or third or fourth wall depending on what the amount of proptosis is, and it causes an increased risk of diplopia. So the treatment algorithm is based on that approach, and we will summarize by saying that mild exophthalmos, fat predominant, you may do just fat decompression. Muscle predominant, you need to combine it with lateral wall. In more than 3 millimeters exophthalmos, fat predominant, you would need to do, in addition to fat, the lateral wall. But in a muscle predominant disease, you need to combine it with medial wall as well. In compressive optic neuropathy, the removal of posterior medial orbital wall and the palatine bone is particularly important. It is a focused decompression of the posteromedial orbit, but you need to leave the anterior part of the medial struct intact to avoid diplopia. And the various approaches are similar to what Santosh told you. Upper lid crease incision is increasingly used for the lateral wall or the deep lateral wall, which is commonly used. And transconjunctival approach with lateral cantholysis is used for approaching the medial wall and floor along with the transcarancular approach. So these are the approaches. This is the crease incision. This is the carancular approach. And you can combine it with the fornicial approach, which Santosh talked about. Worsening of diplopia is the most common problem, although hypoesthesia and malpositions of canthus and lid can also occur. So the final examples are that you can reduce the compression reduce the proptosis very significantly by doing a hidden transconjunctival approach. You can see the reduction in the amount of proptosis that you get in one eye and the other eye following decompression. For congestive disease, similarly, you can take care of the congestion after decompression, again done with a transconjunctival approach, reduce congestion, reduce proptosis, and also improve the optic neuropathy function. This is an example of a cosmetic indication where after the two-stage approach of decompression and blepharotomy, we could improve the cosmetic appearance very significantly. So what is important to remember in thyroid eye disease is that you need to do it sequentially wherever indicated. First orbital decompression, then take care of the motility, and finally the eyelid surgery. And eyelid surgery, eyelid retraction is the commonest thing that you need to do, but you need to ensure that you abolish scleral show and maintain normal lid crease and contour. You can use both the posterior and anterior approaches, including the blepharotomies, Müller's muscle surgery, as well as sometimes for severer cases, you may need to put in a spacer. So these are the results of the various surgical approaches for orbital disease. To summarize, a better understanding of the disease, improvements in targeted medical therapy with decreased functional and aesthetic disability, minimizing the need for surgery, and improved minimally invasive customized surgical approaches have led to much more gratifying outcomes in the management of thyroid eye disease, and we may be looking at a paradigm shift in the management over the next few years with our better understanding. Thank you very much. Thank you, Chitra, for the opportunity to be a part of this AIC webinar for the postgraduates. Thank you.
Thank you so much, Dr. Ashok. It was just an amazing lecture we heard now. Paucity of time, I would have loved to have asked a lot more questions. We need to go on to our next speaker, Dr. Adit Gupta, who's an oculofacial plastic and reconstructive surgeon practicing in Mumbai, trained extensively in this niche specialty, and after completing his PG in PGI Chandigarh, LV Prasad, and then topping it with an international fellowship. He has 22 peer-reviewed international publications and has been an editor of a book on oculoplasty. And today he would be talking on eyelid tumors, how to evaluate them. On to you, Dr. Adit.
Good evening, everyone, and thanks Dr. Chitra ma'am and team ARC for giving me this opportunity to speak in this webinar, which has been conducted wonderfully till now. Eyelid tumors vary from small nodules to fungating masses, which can be life-threatening. So it is very important as a postgraduate and even as a clinician to differentiate between these tumors so as to guide management prudently. What I would be discussing in this talk would be how to evaluate an eyelid mass, how to differentiate between a benign and malignant tumor, and how to differentiate between commonly encountered tumors in the clinic. Now, we all know that eyelid has an anterior lamella and a posterior lamella, and there are various structures which form these lamella. Now, eyelid tumors originate from these various structures, and the classification of eyelid tumors thus becomes simple to differentiate based on whether they are arising from the skin, the sweat or the sebaceous glands, the hair follicles, melanocytes, or various structures found within the eyelid. When we evaluate a case of eyelid tumors, history taking and clinical examination are the most important things because we can make a diagnosis in 95% of the cases just based on these two things. Systemic examination is prudent in cases of malignancies, investigations are needed in certain case scenarios, and surgery, histopathology, and follow-up have a crucial role in malignant eyelid tumors. Now, as a postgraduate sitting in a clinic, if such a case walks into your clinic, how do you evaluate such a case? We don't forget the basic principles of Love and Bailey's surgery, where we know about the onset, duration, and progress of the tumor, the location of the tumor, that is, whether it is on the upper eyelid, lower eyelid, canthus is involved, or if it involves the lacrimal system as well. The extent helps us in prognosticating the disease along with the size, and also helps us to determine which structures are involved and which structures might be involved in surgery. You need to know the relationship of the tumor with the surrounding structures. Like in this case, you can see that it is very close to the lower punctum and the canaliculus. The surface of the tumor holds utmost importance because we can know about the characteristic of the tumor from the surface. A smooth surface indicates a benign tumor, while a bosselated pedunculate surface might sometimes be malignant. Fixity to the surrounding structures like the bone, skin is also a clue as to know about the orbital extent of the tumor. Feeder vessels and telangiectasias point towards a malignant tumor. Presence and absence of pigment can help us classify various tumors. And the anatomy of the eyelid margin and regional lymph nodes also should be examined in any case of eyelid mass presenting to the clinic. Second most important thing that you need to do when you are evaluating an eyelid tumor is how to differentiate a benign tumor from a malignant tumor. So in these cases, you need to look at the eyelid anatomy and the architecture as well. Destruction of the eyelid architecture as seen in this image with rounding of the posterior tarsal margin is very indicative of a malignancy, along with localized madarosis, telangiectasias, nodularity with pearly translucent margins. Ulceration associated with bleeding occurs mostly in malignant tumors. Effacement or distortion of the meibomian gland anatomy and the meibomian gland orifices, along with tarsal thickening. So if there is a clue to all these things, it points towards a malignancy. Now, if you're sitting in a very busy clinic and you get these case scenarios, you might pass it off as a chalazion. But the most important takeaway message from this talk, which I'm giving, is you need to evert the eyelid in each and every case of an eyelid nodule, because sometimes an innocuous looking mass might turn out to be a polypoidal fungating mass beneath the tarsus. Sebaceous gland carcinoma is a great masquerade, and that's what we are going to start the discussion with. Usually, sebaceous gland tumors can be missed off as a chalazion, like this lady where she underwent an incision and curettage, and the tumor recurred bigger and faster after the incision and curettage was done. Eventually, she turned out to be a sebaceous gland tumor. Sebaceous gland carcinoma is very commonly seen in the Indian and Asian subcontinent. It is a relatively rapidly growing tumor causing distortion of the tarsal architecture. It arises from the Zeiss and the meibomian glands, and also can arise from the caruncle. Now, management of sebaceous gland tumor is very important because it has a higher recurrence rate than other tumors. It has a high rate of metastasis if there is a recurrence and if not treated well. And it can masquerade as either a chalazion or a chronic blepharoconjunctivitis as seen in the lower left picture. Management will be discussed in detail by Dr. Kasturi after my talk, but usually we take 4 mm margins, do cryotherapy at the edges, follow a no-touch technique, along with intraop frozen section and Mohs surgery, and then histopathology usually guides further treatment. Preoperatively in the evaluation, it is very important to do lymph node assessment and systemic metastatic workup in the form of a positron emission topography scan, or either a CT scan of the whole body, just to rule out any presence of metastasis before we start treatment. Sometimes sebaceous gland tumors can occur like this, where you cannot delineate the posterior extent of the tumor, and you can see that the tumor is spread beneath the fornix and is infiltrating the inferior fornix and has obliterated it. Now, this is sure shot sign of orbital invasion, but there are certain clinical pointers which can help you determine whether it has spread into the orbit or no. Ocular movement restriction, presence of proptosis or diplopia, ptosis, an evident orbital mass or fixity to the orbital structures of or the rim is a pointer towards orbital invasion, and an imaging in the form of either a CT scan or an MRI scan is prudent in such cases. As you can see that the tumor has invaded the anterior orbit, which is more evident on the axial cut, and these cases then either need neoadjuvant chemotherapy followed by excision or exenteration if neoadjuvant chemotherapy is not indicated. Second, coming to the most common tumor which is found worldwide but a lower incidence in India and dark-skinned individuals is the basal cell carcinoma. Now, basal cell carcinoma has a typical characteristic clinical appearance with pearly rounded margins and ulcerated center. It is usually pigmented, but there are certain variants which can be non-pigmented. It is also called as a rodent ulcer because of its locally infiltrating nature. So it infiltrates locally and doesn't spread systemically. The metastatic rate of this tumor is very low. Most common site is the lower eyelid followed by the medial canthus. Sun exposure is one of the most important factors associated with a basal cell carcinoma. Now beware that not all basal cell carcinomas involve the eyelid margin. There are certain basal cell carcinomas most commonly found on the lower eyelid skin like this, where there is a lucid interval between the eyelid margin and the basal cell tumor. The four morphological forms of basal cell carcinoma are nodular, nodulo-ulcerative, morpheoform, which is more resistant to treatment because it is superficially spreading, and the cystic variant. Treatment of basal cell carcinoma is fairly straightforward, where you need a good surgical margin clearance. Prognosis is good and metastatic rate is low. There are certain forms of medical therapies in the form of imiquimod cream and cryotherapy for smaller lesions. And nowadays, sonic hedgehog inhibitors in the form of vismodegib are available for extensive loco-regional spread. They are not yet available in India, but they are FDA approved in the US. Coming to the third variant, which we see commonly, which is basically doesn't have any pathognomonic features, but is mostly a histopathological diagnosis, is a squamous cell carcinoma. These are rapidly growing tumors. As you can see, the upper slide and the lower picture, you can see that there is a growth within 5 days of the tumor. I had seen the patient first at this, and then you can see it has grown so rapidly within 5 days. It is highly metastatic with a very high recurrence potential. Also, on histopathology, it is very important to know about the perineural spread, because perineural spread on histopathology warrants more aggressive follow-up because recurrence rate is very high. There are certain precursor regions which can cause squamous cell carcinomas like Bowen's disease, keratoacanthomas, actinic or solar keratosis, xeroderma pigmentosum, and radiation dermatitis. Now, not all malignant tumors or not all malignant looking tumors are malignant. There are certain masquerades of malignant tumors also which could be benign in the form of pseudoepitheliomatous hyperplasia. These are basically benign tumors mostly due to fungal infections, and if not treated, they usually regress on their own. Sometimes these tumors also need biopsy from the edges because they can have squamous carcinomas which can reside on the edge of these tumors. Now, coming to the benign tumors which are commonly seen in clinical practice, I won't harp much on external and internal hordeolum, but it is very important clinically. I see a lot of referrals where they have been mistakenly labeled otherwise. So you need to know that an external hordeolum or a stye in layman's language involves the eyelid margin, and conservative therapy is usually sufficient for treating these tumors along with drainage of a focal pus point. While internal hordeolums usually involve the meibomian glands, there is a lucid interval between the eyelid margin and the nodule. It is usually painless, can be painful sometimes if there is an inflammatory change. Now, there are differentiating features between the both, which can be read in any textbook. Usually, internal hordeolums can be treated either with a straight incision on curettage or steroid injection, which has been recently tried for smaller lesions. Now, sometimes these chalazions can also trick you, and we sometimes see these giant chalazions which have a polypoidal fungating internal component. Now, we should not be fooled by these lesions and consider them malignant. This is again a giant chalazion which doesn't resolve only with incision and curettage and might require debulking and steroid injections from the anterior lamina. Seborrheic keratosis and squamous papillomas are again commonly encountered tumors. They are small hyperkeratotic lesions which may be sessile or pedunculated. Classical appearance is that of a button stuck on the surface of the skin. Excision with the help of radiofrequency cautery and reconstruction with flaps works very well for these tumors. Xanthelasmas are again common benign cholesterol deposits which are found in individuals basically who have a tendency of lipid abnormality, or certain xanthelasmas are hereditary in component also. They are notoriously recurrent even after excision and recur because of a deeper orbicularis component. Surgery, electrodesiccation, and chemical peels have been the mainstay of treatment. But not all yellow-looking tumors are xanthelasmas, as in this lady, where you can see that she has yellowish plaques on the upper eyelid, but she has mechanical ptosis on both the sides, along with diffuse thickening of the upper eyelid skin and extension of the tumor beyond the upper eyelid fold. Now, this could be a tumor which could have systemic implications in the form of a xanthogranuloma. It has 4 variants, of which Erdheim-Chester disease has very poor prognosis. So you need to do a proper systemic workup if you have a suspicious xanthelasma, and immunosuppression and debulking along with local steroid treatments works well for these lesions. Imagine a small child, a young child, walking with these small central umbilications and pearly white tumors into your clinic. This is a crop of molluscum contagiosum. These are very contagious, are notoriously recurrent, and thus require very close follow-up. Extraction with the help of an extractor will reveal molluscum bodies, which can be sent for histopathology for confirmation. If there are sudden increase in crops of these tumors and bilateral, you need to check the immune status and rule out seropositivity in such patients. Nevi are again commonly encountered tumors, which are pigmented tumors along the eyelid margin. They can be acquired or congenital, and usually transition from junctional compound to intradermal nevus as you grow in age. They appear at 5 to 10 years of age, grow during puberty, and stabilize during adulthood. They can be pigmented or apigmented. You can excise these nevus very well with a radiofrequency excision. Congenital periocular nevus again is a spot diagnosis. It can be either presenting as a nevus of Ota, where the eyelid skin is involved along with the V1 and V2 dermatome. It can involve the episclera and even the uveal tissue. 10% of these can be bilateral. And the most important point while dealing with these tumors is they need sequential follow-up for fundus evaluation and uveal tract evaluation, because 1 out of 400 of these tumors have a tendency to develop ocular melanoma. This is again a spot diagnosis, neurofibromatosis type 1, which shows either a plexiform neurofibroma, classical S-shaped eyelid, and multiple neurofibromas as seen. You need to do a proper systemic screening along with CT scan of the orbit and brain to rule out gliomas in these cases. Local excision of the big neurofibromas can be done, but otherwise mostly treatment is supportive. Vascular tumors cannot be left apart. Usually, vascular hemangiomas present at birth and involute by the age of 7 to 8 years. But there is a variant of vascular lymphatico-venous malformations or varices, which can present in the eyelid, which usually enlarge on Valsalva maneuver or straining and bending. They can be compressible, and a bruit can be felt on, or a pulsation can be felt if they are high-flow arteriovenous malformations. They can be excised very well if they are small in size, or glue embolization can be done. If bigger tumors like these are suspected and which have a good flow characteristic, interventional radiology can help us in taking care of these tumors. The list of orbital eyelid tumors is unending, and I can go on and on, but due to time limits and to consider that we need to do it from a postgraduate perspective, one take-home message which I would like to give in a routine clinic is any eyelid nodule or bump, you always scrutinize and avert to look at the tarsus, because you could be looking at a sebaceous gland carcinoma, which can, in which time can matter. Thank you.
A wonderful talk, Dr. Adit. I could actually repeat all of what you said. I was so engrossed in it. The best is for the last, and we have none other than Dr. Kasturi Bhattacharya, who's going to talk on eyelid reconstructions, the basics. She's the director of Sri Shankardev Netralaya Guwahati and is a recipient of 30 prestigious awards for her work in ophthalmology, the best of best awards. She has trained more than 80 fellows and is the thesis guide and examiner for DNB and a subject expert for PhD thesis, reviewer of many important journals, 64 publications and multiple orations and awards. And today this amazing woman is going to tell us about eyelid reconstructions. On to you, Dr. Kasturi. Very sorry, I never even realized that this was so long and you've been patiently waiting.
Thank you very much, Dr. Chitra, for the kind.
No, ma'am, we've saved the best for the last. So.
Okay, but I'll do justice. I'll finish everything before 15 minutes, right? Okay, so at the outset, I'd like to thank Dr. Chitra and the team ARC AIOS for arranging this wonderful webinars with so wonderful speakers. So I'll be covering on eyelid reconstruction, which I always believe to be one of the most challenging areas in the reconstructive plastic surgery, because it requires a very delicate interplay of anatomy, aesthetic and functional correction, and the most important is the protection of the underlying globe and the vision. So the key to the surgery of the eyelid is a thorough knowledge of the anatomy, which already Adit has shown very well, but the most important, the subunits of this periocular region, and also the blood vessel and the exosomes, which I'll be discussing later. So Adit has already shown the anatomy, but what is very intricate about the eyelid is, if you look at the eyelid as a such, after the tarsus, you see it has got two lamellae, that is the anterior, which consists of the skin and orbicularis, and the posterior, which consists of the tarsus, the mucosa. But in the same eyelid, when you look to the septal region, it has got three lamella, where we have anterior, posterior, and the middle, which usually consists of the septum and the retractus. So this is what we see, that in the some part of the same eyelid, you have got two layers, and some part you have got the three layers. So during this lid reconstruction, what is most important is that we should replace like for like tissue, and each having the different properties, and we need to respect its functional and the aesthetic properties. So the most important tissues that we use are basically the grafts and the flap, but one should always remember that the graft can be laid over a flap, and the flap can be laid over a graft, but flap can be laid over a flap, but the graft cannot be laid on another graft. So what we understand is that if you look here, the traditional teaching, like all the previous speakers, they have shown that basically how do we replace the lamellar structure? By the combination of either the grafts and the flaps. So if you look at the difference between the graft and the flaps, what we see is that the grafts are basically limited to only the skin. But what the flap consists of the skin, the muscle, and the fascia. It has its own blood supply. It gives a better color. It is more adaptable to the weight-bearing area. And also it can be used on bed with questionable nutrition. And most important is that it can breach the defect. So if we look ahead to this reconstructive ladder, what we know that based on the requirement, based on the complexity, we need to select the procedure, which can be a very simple procedure like this, or we can go ahead with a much complex procedure. But what we need to remember is that we have to give the best functional and the aesthetic result to the patient. So for the postgraduates, it's very important that when you plan for a lid reconstruction, you should know what is the algorithm. Until today, the most important or common algorithm for the lid reconstruction is basically a width-based. So this is a weight-based algorithm which many of us have been following, which is based on the size of the defect and the lamellar involvement, wherein the defects are classified based on the 25% increase of the eyelid width. And if you look to all this, I think this is very important for the postgraduate. If you look to this, like all the four parts of the periocular region where we have a defect is basically divided on the basis of the horizontal width, which can be either a small, medium, large, based on how much amount of the width is being involved, or even in the medial and lateral canthal on the basis of width involved, that is approximately whether it is less than 1.5 centimeter or more than 1.5 centimeter, we usually divide it into small, large, medium, and the large. But what is the most important point that has been overlooked here is that the missing verticals. So what we knew when we do a lid reconstruction, we also need to reconstruct the vertical components. And what we know that with increase in the vertical height, the ability to use the local flaps without giving much tension becomes more challenging. So this led to a very interesting paper where they have divided for the algorithm for the lid reconstruction, they have divided in consideration of the vertical height. As you can see here, on the upper, lower, middle canthal and the lateral canthal region has been divided into 4 types, and they have been further subdivided based on the involvement of the tissue, where type 1A is the area where the tarsal region is involved but not the tarsal plate. And 1B, when you have this region being involved, that is in blue, but it is also involving the tarsal plate. The type 2 is involving the preseptal defect, but it is not involving the tarsus. 3, that is the red zone, that is a lid cheek junction. And if you have a combination, that is a gray out here, or if you have a combination involving the pre-tarsal, pre-septal, and eyelid cheek junction, it is known as a type 4 defect. So based on this vertical algorithm, the many of the reconstructions, especially in relation to the flaps, are being done. And this has also helped for especially the postgraduate to know the competency of the surgery, like how in the FATIQUE we have the ICO Oscar rubrics. In the same way, here also you have a score rubrics for the lid reconstruction in terms of aesthetic and function outcome, where the 4 major criteria: the position, the lid margin, the quality of the skin, and the lateral canthal angle. And then you give a score from 0 to 1, 1 being the maximum and 0 being the least, and you can have your own competency level. So when we talk about the lid reconstruction, we all know that the indications can be either congenital or acquired. I'm going really fast. And this evaluation, I'll not go into details because Dr. Vidya has shown so beautifully how to evaluate the lid. So these are the important points to be taken into consideration. A very important point is the contralateral eyelid evaluation. So when we reconstruct this as a reconstruction of the anterior lamella, posterior lamella, or the full thickness. And the anterior lamella, the easiest, when I was mentioning about the reconstructive ladder, the easiest is this, the laissez-faire, where it goes by secondary healing. But the other anterior lamellar structures that are used for reconstruction are the skin flaps and also the skin, and also the other small procedure. Usha had shown the Z-plasty very well, where we have the 2 flaps at 60 degree transpose in the opposite direction, which helps to overcome all the adhesions and also the scar. And this is how you also release all the cicatrization. You can also use the localized flap, the most common being the bilobe flap and also the Lindbergh's, the rhomboid flap, but also you can have the sliding flap, advancement flap, and a rotation flap. Skin grafting has been shown very well by my previous speaker, which can be a post-auricular full thickness, and you get a very nice cosmetic result. Sometimes a trauma case also repaired elsewhere where it was not repaired well, and in that situation also you might have to give a skin grafting, and you get beautiful results with even with the post-auricular skin. But what is important is sometimes you need too much of skin. In such situation, you need to take a split thickness skin graft. And this is a very nice way of having a large amount of large skin. And this is the requirement, especially in situation like this, in the burn situation, when you need to salvage the vision because of the total cicatrization which has occurred following the burn. And for the posterior lamellae, what we as the oculoplasty surgeon, we prefer is the lip mucous membrane because it is very easy to harvest. But sometimes if you have a linear scar, we go for the Z-plasty. And when you need a tarsus with a conjunctiva, we usually go for the heart and the heart palate graft. So how do we repair the full thickness? The easiest way, when again here we go to the width, the horizontal width algorithm, which many of us are following, but here also we need to see the vertical algorithm. If it is up to 50% of the defect, we usually go for the lid closure and direct closure, and which is one of the easiest techniques was the Burroughs technique, that is a far, near, far, which is a very long incision. But what I believe is simply you do a far, near incision, like 3 millimeter from the incision, 1 millimeter deep, you give a bite, then you go to a near and near. So far, near is also a very simple technique where you put the first suture in the gray line, then followed by the suture in the lash line, the tarsus and the skin. But you should always remember that the end point of the lid margin should be everted in order to prevent a notch appearance in the postoperative period. But if you have a lesion, if you need to repair something between 50 to 70, in spite of doing cantotomy, cantolysis, you're not being able to have a good, a position of the bone, the curtain. The other option is the lateral advancement flap, which is also known as the tensile semicircular flap, usually done it for the lower lid, but also it can be done for the upper lid. So this is a very simple way where you get a very good position by making just a lateral advancement with a semicircular incision, and you can also very nice do a suturing, and also it gives a very good result. But what about the upper defect? When you have a large defect of more than 75%, for the upper lid, we usually do the cutler bed procedure or the master disc lid switch flap or the glabellar flap. So this cutler bed procedure is like what you do when you make need to repair as big a lesion in the upper lid. you have a full thickness tissue from the lower lid and you fill it as a bridge cap. And then you keep it and you separate it after 6 weeks and you have a very nice functional eyelid. And this is a small surgery. This is just a 1 minute surgery. I'll be going fast, and you can see as Adit has already shown the different types of sebaceous gland carcinoma, where these are the lesions which are really very like, because of the vegetative spread, it really ends up cutting too much of tissue, and also the MAP biopsy is very important. What I prefer when you plan for a cutler bed, you have only the anterior and the posterior lamellae without the tarsus. So you need to give a tarsus when you really have more than 75% defect of the upper lid. So I take the tarsus and the conjunctiva from the other eyelid, and this is being used to form the posterior lamella. As in the beginning of my lecture, I was already mentioning, this is the closure of the donor area. Now you go to the recipient area, and this is the big lesion that we have seen. That is a big repair we need to do. So from the lower lid, you need to fashion. This is the dog ear that has been excised. So you're getting the 2 lamellae here, and this is how you send for the MAP biopsy after excising most of the tumor. And now from the lower lid, you have only the 2 layers. So in order to give a tarsus, the structural support, I have taken the tarsus from the other lid, and you need to form, this is the fornical conjunctiva. So what I do, I take the fornical conjunctiva of the upper lid, suture it to the tarsus, the tarsoconjunctival graft that has been taken from the other lid. And then what you do, the lower tissue, that is the flap that you have done, this is the conjunctiva of the lower lid, and this forms the posterior lamella. As I have already mentioned you, it should be formed by layer. So the next layer, as you can see here, this is the middle lamella, which I had already mentioned. It is a levatopalpebral superioris muscle, which is the upper lid retractor. You need to take out this middle layer, and then you need to suture the second layer, which is being sutured to the tarsus. So now you have the 2 layers. So you have formed the posterior, you have formed the middle layer, and the third most important reconstruction is the first layer, that is the anterior lamella, which basically consists of the skin and the orbicularis. I take a bite along in the LPS so that you get a nice, beautiful crease post-operatively, and then you suture, go for the closure of the wound. In 6 weeks, we usually cut this, and this is after the 6 weeks where you need to divide this. Divide the lid, and this is what I'm getting fast, and this is what you can see. We have nicely separated the lid, and this is after that we reconstruct the upper lid, and then for the lower lid, you need to fashion. You need to fashion this area, and then you go for the closure, and this is what we usually do after 6 weeks, and this is the result that you see. This is the same patient having, sorry, a sebaceous gland carcinoma, and you can see a beautiful lid crease that has come, and it looks very much like that of a natural lid. These are some of the patients where you have undergone the cutler bed procedure with a very good reconstruction, and sometimes you see, because these have a vegetative spread, you can see that it has really, you need to do a very big extension. But when you really need to really reconstruct the whole lid, you need to give also structural support. Here I have used a sclera to form the tarsus, and the rest of the procedure is same that I have shown you before, and this is after the separation of the lid. Muscle lid switch is another technique. The importance of this, that you get the eyelashes. So this is a child who came to me with a coloboma when she was 3 years, and then I had the lid switch procedure, and then you can see the end result. You can see the eyelashes out here, and this is a very nice technique. And now she comes to me, now she's almost 18, 19 years, but still I think I need to do a little refinement here, but the advantage is that you also retain the eyelashes in such situation. Sometimes you really need to have a very big excision, the whole of the lid goes. The fixed flap technique is a very nice technique. Like another situation, a sebaceous gland, where the initial, when I have first excised, the frozen section showed the medial ends and the lateral are involved. You keep on cutting it till you end up cutting the whole of the lid. So this is again the tarsoconjunctiva taken from the other lid, and then this is a fixed flap, that is a forehead flap that has been taken, and this is the reconstruction that you see, and it gives a very good post-operative result. And also if you look to here, this legophthalmos is not much there, and it gives a very good closure. For the lower lid, the most common is a modified Hughes flap, and also for a much bigger lesion, we go for the Mercedes cheek rotation or the trapezius flap, which we call the bucket handed, and also the other types of flap. So this modified Hughes flap, which is usually what you have only the posterior lamella that you take it from the upper lid and you make an incision 4 millimeter behind this the anterior part of the tarsus, and this tarsus and the conjunctiva is being switched to the lower lid. And why I was mentioning the condition of the other lid is important, and the surrounding tissue, if it is you need to mobilize the surrounding skin to form the anterior lamella, or you can also use a full thickness skin graft because you already have a flap giving a good blood supply. And again, after 6 weeks or so, you can separate it and give a very good, nice functional and cosmetic result to the lid. And this is how we do. And the Hughes is also another nice technique. This is nice technique because in some situation where that is the only eye, you cannot do a Hughes procedure because the eye gets closed by, I mean, both the lids coming together. So here you can have a tarso-conjunctival flap from the upper and the lower lid, and so you can keep the eye remaining. It can stay as a seeing eye, and the anterior lamella you can also cover with the skin. And the midline forehead flap, which can be done for the upper lid, can be done for the lower lid. It gives a good correction. And in situation like this, when you have the involvement of the whole of the lower lid and also the upper lid, so in this type of situation, you can do something like the TPS flap. And also here I have reconstructed a tarsus by taking the periosteum, and I have divided into two parts, where one forms the tarsus, lateral tarsus of the upper lid, the other forms the lateral tarsus of the lower lid, and then with the bucket and the technique, you can also form the TPS flap. Mustard for the, I think for the students, it becomes too much, but I'm just touching it. It is usually for reconstruction of very large vertical defect. This is the type 4 defect that I have mentioned it. And you need to really reconstruct using a big myocutaneous flap going right up to the tragus. But what we understand, these are just my last 3 slides. What we understand is that all these years we are using the random flap. It can be either a Frick's flap, it can be a rotational flap, it can be a globular flap, or the TCS flap, the TPS flap, or the vascular flap. But what we have realized that what is the maximum blood perfusion that is allowed for the flap, because sometimes after doing such a beautiful surgery, you can have an endpoint necrosis. So this is a very interesting study where they have done the blood perfusion by using a high resolution thermography, and they have found that as we go away from the base, the red is a flap and the black is an intake skin. And the blue, you see, that means there's a loss of blood supply at the tip. So as we go away from the base, what happens? The blood perfusion also decreases. There are lots of studies on it, and you can see that maximum which is being allowed is 3 centimeter, because at 3 centimeter they have shown that 80% of the perfusion is maintained, and it depends upon the degree of rotation. If you rotate by 90%, you can see that if you have the blue out here, that means there's some amount of the perfusion decrease, and if you rotate by 180 degrees, the perfusions are much decreased. So then how do we prevent such necrosis? And the new concept today is the enzyme-based reconstruction. So this is my last slide. What I want to maintain that we should know all the endosomes of the face. And today the use of this concept of the random, the myocutaneous flap that we have been doing is not much considered, especially when you really need a big flap either from the temporal area or in cases of mustardis. So in such situation, we need to go for the enzosome-based reconstruction. And the most important part over here is this endosomes are basically a 3D composite unit of skin and underlying tissue, having a source artery with one side the arteriosome, the other side of the venosome. But most important thing that these endosomes have the choke anastomosis. So because of this, if we look to the face, we have beautiful 5 areas of function endosome, each having its own source artery, which can be either the facial or it can be ophthalmic. And you have this choke anastomosis. So when you go for a bigger flap, myocutaneous flap, it is very nice if you can, especially for the temporal, you need to follow this endosome. And because you have this choke anastomosis here, the chance of flap survival is very important. And also for the mustardy, we can go for the lower endosome. So with this, I conclude by mentioning That eyes are the focal point for the function and the facial cosmesis. There are varieties of technique available for the periocular reconstruction, but the most important, one should have a thorough knowledge about the anatomy. You need to replace layer by layer. And the second most, you need to know about the blood supply. You need to know how the endosomes are being, designed, and this gives a much, better outcome. Thank you very much for your patient hearing.
Thank you very much, Dr. Kasturi, for so much clarity in your talk. I think there might be questions, but we're really running out of time. Any one question, Dr. Akshay, which is to be asked, or shall we conclude?
No, there was one question that came about what is the preferred duration for keeping the flap in cases of lid sharing procedures, especially in children. Do you want it to be shorter, longer?
It depends on whether the technique that you do. If you have a very good vascularity, if you have a very good supply, what the textbook says that it is for 6 weeks. But if you look to some studies, the study says that even you can release at 3 weeks. Why they are saying? Because of the periocular blood supply. And there was a very nice study by the Bortori's group where they have shown that if you have a flap which is approximately 13 millimeter, so if you have a flap with a 13 millimeter, you can separate it even before 2 weeks. But if you have something more than like around 20 millimeter, that is a 2 centimeter, it is preferable to wait for 6 weeks.
All right. Thank you, ma'am. That's all, ma'am.
Thank you so much. I don't have words to express the amount of gratitude we have on behalf of ARC for having had experts with us. And clearly we understand today that the webinars have allowed us to sit at home and get the most of collective information. And I'm sure with the expert panel and the great speakers, we have definitely offered on a platter the very best of oculoplasty to our young PGs. Our special thanks to Mr. Kripal and Mr. Sunil and the AIOS office for their presence and support, Mr. Sai for his constant energy and support, Encode for being the main sponsors for all ARC activities, and my dear ARC members for their support and presence at all times. A heartfelt thanks to one and all of our attendees. Hope this evening was as gainful to you all as it was for me. Thank you very much, one and all of you. Thank you.
Thank you very much.
Thank you.
Great,
to all the experts.
Great talk, Kasturi ma'am. Lovely talk as usual.
I would be forwarding all the links of your talks to remain connected with this our WhatsApp group and
yes.
Okay, thank you.
Wonderful talks by everybody. Thank you so much. Thank you.
Thank you.
Thank you, Chitra ma'am.